extremely competent people that need to come together to deliver good lung cancer care. Chest physicians, thoracic surgeons, med-onc, rad-onc, thoracic radiology, histopathology, organ-specific specialists to do with brain, liver, adrenal mets. And an LMIC, all these people exist in your community, and you can bring them together and optimize the delivery of cancer care through an MDT. And if we think about this is a fundamental challenge in delivering good cancer care. There's the person who takes the biopsy. It could be a chest physician doing an EBUS or a NAV-bronch or a CT-guided biopsy under a radiologist. That person is trying to take safely tissue. It's an opportunity to stage the disease, and they have to achieve good quality tissue. Good quality tissue that needs to be served up to the pathologist so they can make a diagnosis and they can have enough left over to get reliable molecular testing. And that is actually quite a complicated pathway. You need to optimize that pathway. You need to optimize the fixation time so you don't get failures in molecular testing. It's a huge thing that needs a lot of work and attention. The pathologists are looking at morphology, where you can save a lot of money by not wasting it doing unnecessary immunohistochemistry, preserving tissue for adequate molecular testing is critical. The Royal College of Pathologists did a lot of work in the UK in September 2018, issuing this report, talking about minimizing IHC for lung cancer. If it looks like lung cancer on a scan and the biopsy looks like lung cancer, all you really need is a couple of markers for squamous, a couple of markers for non-squamous, and that's it. You don't need to waste your time spending lots of money doing unnecessary IHC. So we then have this complexity of all these patients with actionable genomic alterations, which are basically different diseases. As a lung oncologist, I think of these as different diseases, and I have completely different treatment pathways for them. And so the management of lung cancer is completely contingent on genotyping. If you don't know the genotype of your patient, you really haven't got enough information to know that you're giving the best treatment. So to give you an idea of what genotyping looks like at my center in the NHS in England, my patients who have a biopsy, when the pathologist sees it's lung cancer, will reflexly, without reference to me, without reference to the MDT, automatically initiate molecular testing. They will do PD-L1, ALK, and ROS1 IHC. We're going to decommission the ALK and ROS1 IHC because we think RT-PCR is really quick and gives us a really good result, and we want to preserve tissue. The RT-PCR screen that we do is a 4-panel cartridge. Idilla, we do it because it's got a low failure rate, uses very little tissue, and we accept that there are false negatives, so it's just a screen. And then all the tissue that's left gets sent to a genomic hub. There are 7 in the UK for full RNA, DNA panels, and we also do ctDNA in the UK, and where I am we use Guardant, and that's done on radiological suspicion of cancer. And we're now moving to a situation where molecular testing is tested and reported to what we call our national test directory. We're actually transitioning to using ctDNA, that if it picks up an actionable genomic alteration, we won't waste money doing NGS. We've got our answer. We're going to move on and treat our patients. So I know many centers in India just do single gene testing, but I think tissue is precious. There are lots of other genomic alterations, so I think there's a very strong case for panel testing. I think there's a reasonable case because of the speed and low cost to do an RT-PCR screen, but a positive is a positive when you do that, but a negative is not a negative. You then need NGS to confirm. So NGS remains a gold standard, and ctDNA can potentially reduce the cost and use of unnecessary genotyping. One of the biggest issues we have in the UK, and I'm sure it's the same in India, is genomic literacy. On getting oncologists to understand a report, read a report, know what's genomic noise and use things that don't need treatment and things that do need treatment. So bringing all of this together into an MDM is absolutely critical. Rapid symptom assessment, rapid diagnostics, rapid staging, rapid treatment delivery, and you know, to get the best outcomes. And MDMs are not free, you know. You need managers, you need the whole hospital to be behind it, you need the doctors to have the time to come together, you need administrators to coordinate the list, to make sure all the actions happen. It's not a free thing, it's a huge investment, but it's something that an LMIC can deliver very, very effectively. And one of the things I'd like you to look at in your own time is Google University of Manchester Diagnostic Bundles. This is a really nice piece of work in trying to bundle investigations to really speed up time and diagnostic procedures in patients to get the answer, to get patients on treatment as quickly as possible. Now I'm going to move and talk about actionable genomic non-AGA, non-small cell lung cancer. So immunotherapy is the mainstay of treatment in lung cancer. It's changed the face of this disease in the last 8 years. We've got multiple agents approved, single agent, combo, chemo, IO, but it's hyper expensive. And I saw something presented at World Lung a couple of weeks ago saying that less than 3% of eligible patients get immunotherapy in India, which is, you know, really upsetting to see. The thing about immunotherapy to remember is there is a tail. And what I mean by that is there are long-term survivors that you just don't see in chemotherapy. These are nth-line trials. The first one is a phase 1 study and 2 second-line studies showing 15, 16, 17% of patients alive at 5 years with multiply relapsed lung cancer who went into these trials. Amazing, amazing effects. So remember that you can actually may even be able to cure advanced lung cancer if you get access to immunotherapy. But does it matter? Does it matter to give it first or second? So look at this. This is Keynote 24, paradigm shift trial in lung cancer. First line, high PD-L1 patients, half of them are given immunotherapy, the blue curve, and half are given chemotherapy. And we all know this result. We all know that 32% of people are alive at 5 years because they had immunotherapy first line. But does the line matter? Well, it does, because if you look at that red line, chemotherapy, 66% of those patients switched over and received immunotherapy in the second line or subsequent line. So remember, if your patient's going to get immunotherapy, give it first line. It's always upsetting when you see someone who's on immunotherapy and they're paying the money for it as a second, third line treatment. If they invested the money then, why didn't they invest it first line when they may have had a better result? So if you're going to offer it first line. Can we do things to make IO cheaper? Well, there are different agents and competitor compounds, you know, pharma can argue, but we can look at the dose, the subcutaneous formulations, and the intervals within which we give it. So there's really nice data from this lovely study about the move from pembrolizumab to weight-based dosing to flat dosing from 2 mg per kg to 200 3 weekly, and that we know results in, on average, a 24% increase in the amount of pembrolizumab given. So there are strategies to reduce the cost that may be advantageous to a country like India. We know there's some emerging data about using low-dose immunotherapy. So this is a retrospective audit of patients given 20 or 100 milligrams of Nivo versus standard doses, suggesting good outcomes. And a few months ago at ASCO, we had this Indian study looking at low-dose nivolumab versus chemotherapy, showing a tail, showing some efficacy outcomes for the use of potentially affordable strategies of immunotherapy. What about the frequency? Well, this is a Dutch study called Dedication 1, where they took 750 patients and randomized them to standard dose pembro or reduced dose pembro. And what the outcomes of this showed is no major difference in OS or PFS, which was interesting. And what does this mean? I mean, I think this means that you can, if you switch from weight-based to flat dosing, there's more waste. We can treat more patients with the same investment if we go back to weight-based dosing. But you know, in some countries you can't do that. In the UK, contracting for immunotherapy is done centrally. So I have no ability to switch to weight-based dosing in my country, but you might be able to do that in your country. When you think about dedication, there are actually a whole series of trials that are running across the world, including a really nice study called REFINE in the UK, looking at reducing the frequency of immunotherapy to see what outcomes you can get. And it may well be that in the future, we find that 2 monthly, 3 monthly, 4 monthly immunotherapy may be all that you need for our patients. So we need to improve first-line utilization of IO in India, and we need to do trials, right? This is the big thing. Trials are the way to get patients access to drugs, and they're the way to prospectively test things. If you look at patients with actionable genomic mutations, there are opportunities to reduce costs. I mean, most of these are treated with some form of TKI-based therapy. There are some drugs that are off patent, but they may be inferior. There are generics, there are counterfeit drugs. There are some drugs that are available in different countries. In the UK, EGFR exon 20 insertions have no reimbursed treatment. So some patients are flying to China and buying sunvasertinib for £5,000 for 3 months' supply, whereas amivantamab and chemotherapy in the UK would probably cost you £10,000 a cycle. So it's much cheaper to do that. And maybe there are opportunities. I know some patients in India go to places like Bangladesh to get generic drugs that seem to work. There's question marks over the dose of some of these drugs. Here, with afatinib, we know from LUX-Lung-3 in this analysis that actually 30 milligrams of afatinib seems to be as effective as 40 milligrams. And we've got really good data for sotorasib, which I don't think you have available here yet. But the dose of 960 is a massive overdosage. There's quite a good data set emerging that doses as low as 240 give very equivalent efficacy. So there's a big space in the immunotherapy, in the actionable genomic mutations to reduce cost, but each disease and each drug is different. You have to look at each one on its own merits. Segueing on to early lung cancer in the final part, well, stage 3 inoperable disease is treated with radical radiotherapy, chemoradiotherapy. We've got data about adjuvant durvalumab, adjuvant osimertinib with the LAURA study. So this is kind of pretty set in place, I think. But actually, in the post-operative, perioperative, early resectable lung cancer, there's a lot of exciting things happening because we've now basically transitioned into 3 strategies: a post-operative strategy, a pre-operative strategy, and a perioperative strategy. And you all know about post-operative strategies: adjuvant chemotherapy, adjuvant immunotherapy, adjuvant targeted therapies, really highlighting that stage, PD-L1 expression, and genotyping are essential in early-stage resectable lung cancer to know what the right treatment is for your patient. But if we look at perioperative, which has been the really exciting thing, we've got 2 key strategies: Checkmate 816, which is 3 cycles of chemo nivolumab versus more complex strategies of using 4 cycles and then anything up to a year of immunotherapy afterwards. And this is the schema for all these trials. And if you look at the data from earlier this year, PathCR, major PathCR, event-free survival at 2 years and 3 years looks very, very similar across all these trials. And remember, the first column, Checkmate 816, is just 3 cycles of chemo nivolumab before surgery, nothing else. Much more cost-effective than any of the other options. Keynote 671 did show a survival benefit, but at ASCO this year, we learned that 816, the 3 cycles before surgery alone, also has a survival benefit. And the hazard ratios are very comparable. So remember that drop-off is a real phenomenon. If you don't give your best drugs first, only 40% of patients, only 60% of patients getting any first-line treatment in lung cancer ever get second-line because they drop off with poor PS. If you don't give your first drug, your best drug initially, your patient may never get it. So in summary, cost-effective care in LMIC is a huge challenge. We focus on drugs a lot, but let's not forget about how much the MDM can contribute to cancer care, how much molecular genotyping can contribute. There are multiple opportunities to modify treatments and reduce cost, and we must take patients with us. It's absolutely critical to teach patients about the importance of getting it right first time, molecular testing, and they shouldn't rush into treatment unnecessarily. They need to invest a little bit of time. And doctors don't have the time to do that, so you need pathway navigators, nurse specialists to sit with the patient, explain patient advocacy groups, leaflets, so that they understand what's going on. Because if you keep the patients with you, then you can achieve, anything. That's it. Thank you very much.
Thank you, sir, for such a valuable insight and practical guidance. The floor is open for questions.
Thank you, Riaz. always comprehensive, always fantastic.
Hi, Nitesh.
Hi. So we obviously are going other way around. You showed a wonderful slide on IHC requirement. It's very logical. Why do we need that? And I think we are doing more and more IHC. We are certainly doing more molecular testing, and one of the reasons why that kind of dichotomy remains is because we're really not sure on, or we want to be very confident on not missing the key target. So is there any very simple strategy that we don't miss target? Where everybody else can get immunotherapy if they can afford. So is there any very simple strategy? Because tissue remains an issue, and liquid biopsy is still not good enough to say squame versus adenosquame, which truthfully in our part of the world is a big problem. We're seeing a lot of smokers with adenocarcinoma, for example. So just your view on that.
My view on molecular testing.
So if you have less tissue, how should we triage that tissue towards?
So this is a very important point, and this is one of the reasons I wanted to reference the MDT and talk about the biopsy taker and the pathologist. Because when you work as a team in an MDT, the pathologist in your MDT talks to the physicians. And when a doctor does an EBUS and it fails molecular testing, and 3 weeks later the same patient is back in their clinic because they're doing a repeat biopsy because the initial one wasn't good enough, you know, sharam aa jata hai na, right? You feel bad, right? So what happens is the whole system changes. The person taking the biopsy takes more passes first time. They learn. You learn how much tissue you need to get molecular testing. So we used to have, when we started genotyping in lung cancer in the NHS, 30–40% of my patients would have failed genotyping. Routine. How much is it now? I would say it's less than 5%, right? It's not that common. It's nothing to do with fancy tests. It's nothing to do with spending money on drugs. It's just the doctors working in a team, talking to each other, developing a system that works.
What is your view on doing these molecular testings as a reflex upfront? If we have a very early lesion, T1, which may be under consideration for SBRT or resection.
So I often think about this. Now in the UK, we have huge pressure to make a diagnosis quickly. So if an advanced patient has the pathologist doesn't know. Often if you look at the report, the request form, that our pathologist shows us, this was on our request form, EBUS biopsy. It doesn't say what the stage was. It doesn't say that there were liver mets or brain mets. The pathologists don't know that information when they're looking at the patient because they can't see the scans, they're not in front of them, right? So in the UK, if the pathologist waits for the MDT to say this is a stage 4 patient, do molecular testing, that's 2 weeks wasted already. Then they start molecular testing. You're not in a position to treat the patient for 2 months. That's not acceptable, right? So we find it easier to just test everything. Now, it is true that that means some stage 1 patients get genotyped unnecessarily. I accept that. But many of those patients actually end up relapsing 2 years down the line, 1 year down the line, and you've already got the answer. You've got their genotype, right? So I actually it doesn't cost us anything. Our patients aren't paying. But I think if my patients were having to physically pay their own money, then yes, I think we would probably try and encourage our chest physicians to write on the request form, you know, that what is the stage of this patient is advanced, please genotype if it's lung cancer, versus this is a stage 1 patient. But our pathologists just don't know at the time they look at the tissue. And we want to rush everything through to get patients on treatment as quickly as possible.
In the era of neoadjuvant immunotherapy, where do you think neoadjuvant chemo radiation stands in stage 3 disease, especially for bulky nodes? Do you think still has a role in certain cases? And in your practice in UK, where do you utilize neoadjuvant chemo radiation at all in the practice, or it's just neoadjuvant either chemotherapy or immunotherapy?
Yeah.
And secondly, will there be a phase where we'll be just utilizing neoadjuvant TKIs and not immuno, especially in mutation positive patients, not chemo and not immuno, just neoadjuvant TKI? Will there be ever a phase where we'll be able to utilize that?
So the first question, which is about neoadjuvant chemo-RT, so the data space in lung is basically diverged into two, and forget stage 1, I'm talking about stage 2A to 3B resectable lung cancer. Basically, at MDT, it's divided into two avenues. This is resectable, this is not resectable, right? Resectable does not mean if you shrink it, I can resect it. That's not resectable, right? Resectable is, I will take this patient to theater tomorrow and resect them. I'm happy to do that, right? Anything that isn't that is by definition unresectable. For us, that unresectable disease is unresectable, chemo-RT, adjuvant durvalumab, adjuvant LAURA, whatever you want, right? If it's resectable, and it's 2A to 3B resectable disease, and the patient's fit and there are no contraindications, we would give a peri-operative strategy. And all those regimens, apart from 77T, so in the UK, Checkmate 816, 671, and Aegean are approved. I can take my pick, right? So what's happening in the UK is, I would say in general, we will pick one of the 671 or Aegean, because we want the option when the patient comes back after surgery and they've not had a path-CR, that we can still give them some immunotherapy. But I think if in a low-cost setting where cost is critical and I was paying my own money, right, it would be very reasonable to do 816, because it's amazing what outcomes you get with just 3 infusions of nivolumab. It's astonishing. Now, the second question, which was about TKIs, we genotype these patients, right? Immunotherapy does not have any activity in EGFR or ALK disease. I don't care what anyone says, what the PD-L1 expression level is. In the UK, we just don't do it, right? And every trial I've seen would suggest to me that it's inert. But I know practice varies across the world, right? So EGFR, ALK, and ROS1 patients, we generally don't go near immunotherapy. They've got a separate pathway. You know, the pathway for EGFR and ALK patients, if they're upfront resectable, is resect and then give adjuvant TKIs. Now, you're quite right to bring up neoadjuvant. So there's some studies that have been presented this year about neoadjuvant alectinib and neoadjuvant osimertinib. The alectinib data actually looks really good. I'm less convinced about the EGFR data, but it's good enough probably to get a license. So it depends. I mean, if you're going to wait 6 weeks to a month for the patient to have a resection, because that's how long it takes to do everything, put them on a TKI. You can't lose.
Sir, we get many cases with morphologically we see that this is adenocarcinoma. And patient has a lung mass without any other primary elsewhere. But on immunohistochemistry, we usually put 2 markers, P40 and TTF1, to save the tissue. But sometimes TTF1 is negative or focally positive, and morphologically it is looking like enteric type adenocarcinoma. So whether to go ahead with NGS or molecular marker, or to perform further markers to confirm whether it is enteric origin with CK20 and SATB2 or CDX2. So whether to go ahead or...
So, I mean, in general, because our experience of this, so we know you get that in lung cancer. You know you get TTF1 negative lung cancer. It's a recognized phenomenon, right? So we do very good imaging. So CT chest abdo-pelvis on a 64, 128 multi-slice CT with contrast, abdomen, chest, abdomen, and pelvis, that's routine. We will do a PET scan. So I think if all those investigations are saying there's nothing below the diaphragm, we will generally treat it as a lung cancer. And anything non-squamous gets genotyped. We're slowly segueing into genotyping squamous patients. You know, I said that we do ctDNA at radiological suspicion, so we don't at that time know whether it's even small cell. So we're doing a ctDNA very early on. So we are ending up genotyping through liquids, some small cells and some squames. But in the UK, that's not a big, small cell is like 10% now. Squamous is like, of non-small cells is probably less than 20%. It's really petering out. So it's not that big a deal for us.
Sir, in your practice, how often you find to change in the status of this or the actionable mutation? Means as the survival of patient increasing, so every time patient lost the response or progressing on the current ongoing treatment, is it fine to do repeat biopsies to see the actionable mutation, or what's your call?
It's a bit muffled. Are you asking me about re-genotyping patients with a known mutation? Yeah, so this is, so there's things we know and things that are more in the research space. So we know about certain resistance mutations. We know, for example, in EGFR patients on osimertinib that they get C797S, they may get MET amplification. You could argue that there are some potential strategies for that to treat that condition. If you look at ALK patients who've had alectinib or brigatinib, there are certain ALK mutations that confer resistance and may be sensitive to lorlatinib. So there are recognized acquired resistance pathways which would change your practice, and so it's not unreasonable to do that. But at the same time, many patients with actionable genomic mutations will not have that, and you end up doing things that are almost experimental and just inquisitive for the sake of. Now, I could do that in the UK. It wouldn't cost my patient anything. It wouldn't cost me anything. I'm not paying. The patient's not paying. Fine. But when the patient's actually paying out their own money, I'd be much more careful about picking what test to do and when. And this is an evolving space because I think there's a new concept emerging about minimal residual disease and mapping using ctDNA technologies, patients in remission on TKI to pick up PD early. So that's experimental. That's not standard of care. It needs to be prospectively validated in randomized trials.
So with the landscape of neoadjuvant chemo and IO as well as radiation changing, we now do see patients who come up for surgery even for sleeve, vascular sleeve as well as the bronchial sleeve. How do you see it? Do you think it is actually like in your center? What is your experience of your team actually in those surgeries? Vascular sleeve and the bronchial sleeves, post neoadjuvant chemotherapy.
Sleeve resections?
Yes.
Oh, so. I mean, I don't tell my surgeons what operation to do, right? So, we're very respectful of each other's boundaries. Some of my patients have had neoadjuvant treatment and have had sleeve resections, and then the pathology report comes back and it's a path CR. And you think, did they need a sleeve resection? But I think a surgeon needs to do the best operation that they feel is appropriate for that patient. Their aim is to get an R0 resection, and that's what they got to do. And our aim as oncologists is to shrink it down as much as possible and see if we can get a path CR. We're complementary. We're not competing against each other. We're on the same team. And, I just don't feel I have any role in telling a surgeon what operation to do. Most of the operations my patients get now are robotic resections, and the vast majority are lobectomies.
Thank you so much, sir. That was a wonderful start to our day 3. We now move to our first panel discussion of this session, that is MDT in non-small cell lung cancer management. I invite our moderator, Dr. Ashish Singh, sir, professor and head medical oncology, Christian Medical College, Vellore, to take charge of this session. Joining him as panelist would be Dr. Saurabh Jain, sir, surgical oncologist, American Oncology Institute, Raipur. Dr. Sarthak Moharit, sir, consultant radiation oncologist, Apollo Hospitals, Bilaspur. Dr. Sandeep Oja, sir, consultant and head of the department, Oncopathology, Balco Medical Center, Raipur. Dr. Siddharth, sir, consultant medical oncologist, Apollo Hospital, Navi Mumbai. Dr. Varsha Vishwanath, pulmonologist, Raipur. Dr. Vivek Patel, sir, consultant surgical oncologist, Sanjeevani Cancer Care Hospital, Raipur. Dr. Shreyas Reddy, consultant radiation oncologist, Apollo Hospitals, Jabalpur. Dr. Kushal Gupta, Consultant Medical Oncologist, AIMS Kalyani. I would also invite Dr. Riyaz Shah sir to join the chairpersons for this session, and Dr. Dipanjan sir as well. Over to you, sir.
Very good morning. I think Dr. Riyaz has nicely set the tone for choosing wisely, which happens to be the theme of the meeting, and I'm lovely to have such a panel which kind of, because when I looked at the panel I said, okay, we would just restrict ourselves to non-metastatic lung cancer, and that's where all the buzz is, and we are all very mindful that we only have about 30 minutes, so I think my panel is fully prepared, because I did share some WhatsApp messages with them and saying, so they all know what is expected out of them. So now, when we talk about early lung cancer, you all heard Dr. Riyaz saying in the MDT we would say resectable or non-resectable, and we have that dichotomy. However, even if you look at patients who can be resected, just look at those survival curves. We so-called call them early stage lung cancer. Now you may challenge that this is older data. This is, in today's day and world, we are kind of doing much better. But still, in general, our treatment approach is very much into black or white, resectable, non-resectable, right? And this is 2025, and if you just look at what has happened in the lung cancer space. Now, the first curve was one of those very famously quoted different doublet comparison. And when I was training in medical oncology, someone told me, why do you like lung cancer? Just go sit in that OPD in Tata Hospital. Every other patient is suffering, and then you can't do anything about it, right? And from there we have come so much far ahead. And if you just look at, I'm just talking, these are all patients with advanced disease, and if you look at the Crown results, the median is not even reached. Dr. Riyaz talked about the immunotherapy. We just saw FLORA-2, the median overall survival is 4 years. A median overall survival of 4 years in metastatic lung cancer, and this is just one slide from the recently concluded WCLC. These are all patients with metastatic KRAS G12C mutated lung cancer. And you look at the waterfall plot, so this is almost like maybe like a lymphoma waterfall plot, right? You can argue it that way. So now with so much changing in lung cancer, now how do we use all these? How do we, I mean, this is just medical oncology slides, but I'm sure the radiation techniques have improved, the surgeons have improved. You've got VATS, you've got the imaging, the staging, everything has changed. So now with all these things, and also thankfully in India, we can choose wisely in the sense that we are not dependent on what is reimbursed, what is not reimbursed. It's all about, and sometimes, I mean, you can see it as a restriction, but I also see it as an opportunity to kind of still have that clinical judgment or kind of a reasoning with the patients on how do we make decisions. Okay, so this is just one patient I have put to kind of just start the discussion. And this is a 58-year-old gentleman who has come with cough and some little bit of hemoptysis. And if you look at the CT scan, as you can see, there is a mass in the upper lobe, and this is in close relationship to the vessel, particularly SVC. And also you see some sliver of fluid in the pleural space. So let me start with my panel. Do we have a radiologist? No, right? Okay, so we can start with the surgeons. Because that's where so the patient comes to you, and how do you proceed from here? And so,
hello.
So, in this, with the what is the age of the patient? Sorry.
58.
58, and it's a centrally, more centrally located close to the vessel. I would like to get a biopsy and preferably either a CECT of the chest, abdomen, pelvis, or a PET CECT.
So the biopsy is adenocarcinoma.
Okay.
So talking about PET-CT, is it in your practice? I mean, this is about choosing wisely. So is it a must that in a country like India that everybody should have a PET-CT and MRI brain in a patient like this, or what if PET-CT is available not in the city? So are you happy with just a CT brain and a good CT?
Right. So I won't say it is a must, but yes, it changes management in a percentage of patients where you find metastatic disease, and then your whole approach changes. So if it is possible to have it, especially in these centrally located advanced lesions, it is better, but it is not a 100% must that would
So let me give you the information. Okay, we did a PET-CT, and this PET-CT, in addition to what we see here, it did show N2 nodes in the mediastinum, non-bulky, but multiple N2 lymph nodes.
Okay.
So we also have a pulmonologist, right? So do you want to get involved here in terms of accurate staging?
Yes, I think PET-CT should be done because this looks a little bit difficult to access. We'll have to do an EBUS, at least a basic bronchoscopy. And if the effusion is a little bit more towards the lower part, I think we could do some sampling of the pleural fluid at least.
True. So
because
talking
I think
about
this would require CT-guided lung biopsy, and from the anterior part, I don't know how much easy would that be.
That's right.
Because once we get the further how much the extent of the disease is, then only we'll be comfortable with doing a procedure. So if it is an easily accessible site, I think that would be a better option.
So what's coming out is that we do want to get a sample. I mean, the sample was easy, CT-guided biopsy. Now, what about the mediastinal staging? Any other surgeon in the panel? I mean, how important is an accurate mediastinal staging here in your decision making? And how do you go about it? Do you take help of EBUS in your practice? What is your take on, say, mediastinoscopy?
So
anyone? Yeah.
So the practice that we used to do at Tata Memorial is that initially we would send the patient for EBUS. If they are positive, then we won't subject them to mediastinoscopy, but all negative EBUS would get a subsequent mediastinoscopy. The reason being that there is still 8 to 15% false negative rates with EBUS. EBUS needs expert cytologist, and it's more of a skill-based. If you don't target your nodes properly, you may miss out on the positive nodes, and that is going to have a lot of implication on your treatment. So that is how we used to proceed.
So you're talking about the sensitivity of a PET and an EBUS, and I mean, I think most literature quotes it around to be 90%. Now, let me involve my medical oncologist. Dr. Kushal, are you interested in that pleural effusion? Would you want an ultrasound-guided aspiration of the pleural effusion, and will it change the whole discussion?
Yes, it will change the whole discussion. It's better to get a pleural tapping done to, just for the cytology part of it. So that will change the management actually.
Right. So would you just straight away go and treat like an advanced disease if the pleural effusion comes positive? Now I did mention that the SVC was involved. So the radiation oncologist in the panel, would you just say that this is okay? Assume that we have ruled out a pleural fluid being positive, multiple mediastinal node, SVC being involved. Would you say that this patient is for upfront chemoradiation? Dr. Shreyash? Or Dr. Sarthak, anyone?
Is the pleural fluid positive?
No, pleural fluid is negative.
Negative, yeah.
Multiple N2 nodes.
Patient has any symptoms of superior vena cava obstruction?
No, clinically no obstruction. But technically, this is where maybe the surgeons also can come in. Would you want this patient to go neoadjuvant and then surgery, or straight away chemoradiation?
So multiple mediastinal nodes, centrally located mass, plus close proximity to the vessel. It would be discussed in MDT. taking patients.
You are the MDT today and choosing wisely.
So particularly I would say that with multiple mediastinal nodes and a bulky central disease with close proximity to the vessel, we would preferably send the patient for chemoradiation, definitive chemoradiation. But had it been just a single node, then I probably may have considered.
Dr. Kushal, would you do an NGS on this situation?
Yes, I will go for NGS because it advanced.
And why?
Advanced stage 3 disease. So.
And so why are you asking for NGS? I mean, what if EGFR is positive? Suppose there's an exon 19 deletion.
Yes, so
how does that change treatment?
EGFR is positive, then there is role of osimertinib in the adjuvant setting if you are think that it is resectable and
Right. So you would do the molecular testing, but you wouldn't act on it, even in a patient with maybe I can ask the other medicals. Dr. Siddharth, would you argue saying this is advanced disease? There is EGFR exon 19 deletion. What do we get with chemoradiation here? Should we just start with systemic therapy?
Sir, ideally if it is unresectable and we have to plan only chemo.
I mean, your surgeon sitting next to you has said this is he doesn't want to operate.
He has already told that it is probably an unresectable disease. Yeah. So we are going to go with chemoradiotherapy first, but knowing that it is EGFR 19 positive, we can add it in a post chemoradiotherapy as per the LAURA trial, because that has shown the benefit.
So as of now, the approved indication is no neoadjuvant TKI based treatment. What if this is there's no mutation, however PD-L1 is positive, and how about anybody in the panel who would do chemo immuno here, right up front?
So that can also be done, we can if it is all the targetable mutation.
This is stage 3. Stage 3, by the way. So, okay, yeah. Stage 3, borderline resectable.
That you are going to go ahead with a surgery, then probably neoadjuvant chemo immuno makes more of sense. Otherwise, you can directly.
Right. So this is just to highlight. That stage 3 is such a heterogeneous group, and depending on the location and the extent of tumor, one can actually think of, and also someone asked the question, do I need to do molecular testing in a non-metastatic disease? In today's day and age, I think it's a must, because everything depends on that. The prognosis depends on that. The options depends on that, and we must be doing it in that. So now let's jump into neoadjuvant in earlier stage disease, and this is just a slide which shows you how much has changed in the last say decade or so. And now you've got EGFR TKIs, ALK TKIs, checkpoint inhibitors, everybody in this space, and it has definitely impacted the prognosis. So much so that if you look at how the field is moving, we're even kind of questioning this whole thing about whether all stage 3 behave the same, and with these fantastic responses, you see a lot of. Someone asked the question, would you do CTRT followed by resection? Someone asked, so what Dr. Riaz was saying that, I mean, even though technically our guidelines will say on day 1 you decide what is resectable, what is not resectable, but that I feel is going to change very soon. Very soon. Even if you see what is resectable, the definition varies between one society from other societies, right? And I'm not a surgeon, so maybe I'm not the best person to discuss this. And this is just a slide I borrowed from the last WCLC, and even these guys are debating, right? What is resectable? Resectability is so subjective, and if we don't resect, what do we offer? We offer them chemoradiation, right? And what does chemoradiation achieve? Chemoradiation would achieve a complete response in how many? Just a handful. So in remaining patients, you're going to end up with residual disease. Right? And even if you resect and you end up with, say, a little bit of positive margin or a disease in the liver. I know these are all controversial statements. For the students in the audience, this is still evolving. But I think if you want to do lung cancer, it's a very exciting area right now. And what is unresectable with the kind of agents we have, will definitely may become resectable very soon. So now this is the same patient. You see the scans is dated 27th February and 5th August, right? And now you see what has happened. So of course we did systemic therapy first. We did systemic therapy first, and mainly because my radiation oncologist felt the field was too large for him. The pleural effusion was there, right? And this patient did have exon 19 deletion. Okay. So Dr. Kushal, in this situation, what would be a systemic therapy?
So sir, this patient has got CTRT after,
No, exon 19 EGFR.
Oh, so patient was put on exon 19 EGFR, this thing. So, yeah, so after this, the patient has maintained a good response and it was pleural effusion negative.
Pleural effusion we didn't test, it was a small...
Okay, so we will again put it in the MDT and just see if we can, do the, I can see some residual disease.
So the surgeons were not willing to operate. The radiation oncologist said the field is too big.
Okay.
And the pleural effusion, they said give systemic, we will see later.
Okay. So
now this is something which I think in my practice we are encountering a lot, right? In this situation it was exon 19, so we used a TKI based approach, but we recently published a series on a lot of these patients not amenable for upfront CTRT. We give them chemoimmuno and excellent responses, right?
Yes,
in that situation, do you follow it up with say surgery now or radiation now or chemoradiation
now? So we will have to ask the opinion of the, we will discuss it in the MDT and ask the opinion of the surgeon if the, this remaining of the disease is resectable.
Mm-hmm. Yes, so the surgeons now.
So tough situation. How many nodes, so what station nodes were positive?
It was N2, multi-station but non-bulky.
Not bulky.
Yeah.
So, and the radiation oncology is unwilling for chemoradiation, was unwilling.
No, so now we are doing MDT again. So this is after a response. So I'll just tell you exactly what we did. So one of my students is doing a study on alternate day osimertinib. Now this, again I'm mentioning it here because this is choosing wisely. A lot of our patients can't afford osimertinib. If you look at a lot of Asian data of 40 milligram per day osimertinib also is effective. Look at the half-life of the drug is pretty low. So we can actually check plasma levels of osimertinib and see what the target level is. And most patients do have the levels in the therapeutic range. So this patient did receive cisplatin, pemetrexed and osimertinib alternate day, and this was the response. And we all know about immunotherapy, how we use it in sometimes for patients who cannot afford the full doses. There's enough publications out there from India itself where we use lower dose immunotherapy as well in an appropriate patient. So we do get these kind of responses. So surgeons, you willing to operate?
We can, but it's a tough situation with multiple non-bulky multi-station N2 nodes. Although it is technically resectable disease, but I would discuss and weigh the options with the patient and explain both the options, CTRT versus doing a surgery now. There are groups which are doing surgery for multi-station N2 nodes, non-bulky. So there are certain groups, but we were actually following only for a single station N2 node and not for...
So Dr. Siddharth, would you, as a medical oncologist, would you say just continue osimertinib, but why do we need to do local treatment?
So because the response is very good and we are seeing disease only at one place, maybe I will not send it for surgery, but I would like to know the opinion of radiation oncologist if we can give CTRT, so I would be more pushing for that. Right. And if at all he said ki maybe CTRT may be too toxic, like there are phase 2 trials of giving consolidation local RT also, and there was some benefit, although we don't have a very
So maybe I can ask Dr. Riaz, I don't know sir if you have a mic. This is a very common situation now with our ALK TKIs, EGFR TKIs. Do we need to pitch it, do we need to come in now with local treatment, or we can wait till progression?
So these are tricky questions. I think in our practice what we would do is we would say that chemo-RT may be an option. We would bring it back to the MDT and ask the radiation oncologist as to whether they think the volume is treatable. That's one question. The next question is, what is the appropriate time to do it? If the patient has had such a beautiful response to osimertinib, they may receive catastrophic toxicity from chemo-RT. Esophagitis or radiation pneumonitis, you're giving a TKI that we know can cause ILD. So I think if it was a really well patient, we would probably do PET surveillance on this person and try and pick up very early progression and then do the chemo-RT.
True.
That's probably what we would do.
Right. So I think even in lung cancer, I think our approach is now shifting predominantly to continuing on the systemic therapy. Wait for, as he said, oligoprogression or oligo-residual disease, and ensure there is residual disease before you jump in. Now this patient, actually, our surgeons took him up for a surgery, and it was intraoperatively he felt all the nodes were bulky and it was difficult surgery, but he did the surgery, and finally in the final histopathology, all the lymph nodes were negative, and this residual tumor only had 1% viable tumor cells.
Oh.
So subsequently now, Dr. Siddharth, would you advise him to continue adjuvant osimertinib? And
so we have operated the patient.
Yeah, we have done surgery. So only 1% viable tumor, all lymph nodes negative.
Yes, I am going to continue.
Adjuvant osimertinib for how long?
So at least for that trial, 3 years. I am going to continue.
So when you say choosing wisely,
I am going to consider it as a pseudo-adjuvant kind of a thing, because it was unresectable to begin with. So I am.
So Dr. Kushal, will you be comfortable stopping his osimertinib at 2 or 3 years?
Sir, I will be comfortable for at least beyond 2 to 3 years. At least 3 years is recommended, but it depends on the finances of the patient.
True. Yeah. I don't have time to show, but I think even at 2 years, when the osimertinib was stopped, after that, some people, especially in advanced stages like this, they do have a risk of relapse, particularly CNS. So of course, the discussion, I think we should not wind up before discussing some immunotherapy. Now, this patient, if he did not have a mutation, we would have given him checkpoint inhibitor, right? And slides are not moving. Okay, so these are all the trials which we have, and we do not have like 1 or 2. We almost have if you can count there, almost 9 to 10 trials we have in this space. And if you look at the results, 816 was only pre-surgery immunotherapy, but in the other trials they were all had continued beyond. So in India, how do you choose? How do you make your choice, Dr. Kushal?
Sir, essentially it depends on the finance of the patient. So whether we can add immunotherapy or not in the perioperative setting or preoperative setting.
So of course, so how do you discuss that? Because this is important here. So do you discuss, when you discuss finances in Kolkata in AIIMS, how do you discuss that?
So as with almost equal benefits with pembrolizumab and nivolumab, it is, I think nivolumab is much more cost effective, and it has got an endpoint of three cycles. So that becomes, and the response rates are also great. So I think that becomes our natural choice.
So Dr. Siddharth, so you think that they're all the same? I mean, you would like to use any immunotherapy you can lay your hands on, whatever fits the pocket. And based on this data, you're convinced that just the pre-operative regimen, just the 3 cycles will probably be as good, because Dr. Riaz also showed in his talk, we do have an improvement in overall survival now, right? So if you look here, overall survival in Checkmate 816, 55 versus 65, right? Correct?
So if like Checkmate 816, I think is the most convincing way, because we are
okay, so let me ask you a difficult question. Checkmate 816 is with nivolumab, right?
Yes.
Patient cannot afford full dose of immunotherapy. Would you use a low dose nivolumab, or would you use a cheaper immunotherapy like, say, tislelizumab or toripalimab or serplulimab?
So I would go with nivolumab.
Even if you use 40 milligram, you feel that these drugs should not be interchanged.
So low dose nivolumab, no.
So low dose nivolumab versus full dose toripalimab.
So I would go with full dose of drug which has shown some benefit in trial rather than.
So, okay, maybe we'll ask Dr. Riaz. Dr. Riaz, what would you do? I know you're thankful you don't have to make these choices, but we have to make this every day.
Yeah, I can't answer that question. I'm never in this position. I mean, I would do what the trial.
The trial. So you would use the.
I'd be nervous about using something that's not being I would be happy with durvalumab, I'd be happy with pembrolizumab.
No, so if you look here, sir, like Tori and Tisli are much cheaper, and nivolumab is much more expensive. So should we use a lower dose of an expensive drug or a full dose of a drug which we have data for?
Well, I mean, I would go with full dose.
Right.
It's a lot cheaper, is it?
It's much more cheaper.
Seems reasonable to me.
Sure. Okay, how much more time we have? We have about 5 minutes. Okay, so now let's quickly rush to say, so immunotherapy, again, I think that if there's one take home, the take home should be that we should try to use it as Dr. Riaz also said in his talk, as early as we can. And there's no better time than giving it neoadjuvant in any tumor which is 1B and above, and all the way up to 3A according to resectability. But I think this space is going to change very soon, and even in 3Bs, like how we saw in breast cancer, the same thing is going to happen in lung cancer, that resectability, should it be decided on day 1 or should it be decided after induction? So we're going to enter such an era. Now coming to TKIs, I think EGFR we already discussed some, so I don't have time to show you this EGFR TKI data. Now let's talk about liquid biopsies. Now again choosing wisely. So in situations where adjuvant TKIs is so expensive, would you restrict yourself to only people who are, say, MRD positive? Is that a wise way of choosing these expensive adjuvant therapies?
So I don't think we have still conclusive data on that. So till that, I will use it as per the guidelines only. But maybe that
so
is,
like
that
a
is
patient like ours, he says I'm struggling to afford adjuvant osimertinib. Would you just track his plasma and bring in the treatment if he's plasma positive?
Yes. So like I think in those patients doing that is okay, but the cost of even CTC monitoring or MRD
you're saying the cost of monitoring is also an issue? Yeah, I mean that's true. That's true if you want to do the Guardant, but there are a lot of Indian labs which you can even do a DDPCR.
How frequently to do it? Because
how
if you are
frequently
doing
to do
it
it
very robustly, then it is not going to solve the purpose.
So outside clinical trials in the UK, sir, do you do plasma monitoring? No, not outside clinical trials. All right. Now quickly touching upon ALK TKIs. Now again, as you said, the only adjuvant trial we have is with alectinib. This WCLC we saw in negative trial with crizotinib, and I was so hoping that at least we'll have some signal there, because crizotinib is now generic here. So the only option we have now is alectinib, which we have a trial for. Lorlatinib, we do not have the adjuvant data yet, but looking at the lorlatinib data in advanced disease, I mean, I would be surprised if that's not a positive trial. Now how do we choose wisely regarding using TKIs, especially adjuvant? We have only a few minutes left, so anybody wants to take this?
So please.
ALK positive lung cancer post resection, stage 3. How do you?
So right now, I think it is not approved by certain guidelines, but EMA has, I think, approved it. So maybe we can use it because the DFS benefit is too huge.
Sure,
that
because the benefit is quite substantial.
Yeah.
Quite substantial here.
A hazard ratio, I think, is there. So it is.
So Dr. Kushal, what dose of alectinib would you use? The Japanese dose, the American dose?
No, the standard dose, sir. So for 1 year.
Right. Any other strategies? I mean, your patients, I mean, you have any experience with alternating dosing schedules in alectinib? No? Okay. So I think I'll just share here, I mean, Tata is running a trial of 25 milligram per day lorlatinib, and that's as good as full dose, at least in a lot of our patients. And also like, we have learned this from our nephrology colleagues or some heme colleagues also. Like, if you use the CYP3 inhibition here with sometimes, I'm not saying about adjuvant, but we've had patients in 3rd, 4th line where you can't afford any other ALK TKIs. We have used a little bit of ketoconazole or itraconazole to kind of jack up the levels of lorlatinib, and that works wonderfully. So with that, I think we'll wind up. And any other comments from the floor?
Sir,
or
one
any question?
question I just wanted to make to you and Riyaz sir, both of you, all of you, to all the panelists also. So, like, how frequently do you rely on the, while explaining to the patients about the newer agents, immunotherapy agents, how frequently do you rely on the ESMO MCBS scale to explain to them the magnitude of benefits?
So you're asking about MCBS scaling,
Yeah.
about the magnitude of benefit.
Yeah, so
now these agents are improving overall survival, and not by small margins, by huge margins, right? So when you haven't, so I'm assuming this question is for early stage.
Yes, sir.
Yeah. So in this situation, I think 3 cycles of checkpoint inhibitors now most people can afford, right? And if there's an improvement in overall survival, I think this should change practice across. Now the issue happens, what do you do in advanced stage where the treatment is going to be long? I mean, it's not just a few cycles. Thankfully, with support programs now, it's to the tune of say 6 to 8 lakh rupees. Continuous therapy. But in our practice, it's not uncommon to have a patient where you get a response after 3 cycles or 4 cycles, and subsequently you don't have to stick to 3 weekly dosing. And this data we do have. If you look at even the other trials now, they give it every 6 weekly or sometimes even every 12 weekly. But what the pharmaceutical company will do is they'll double up the dose. That's not a scientifically, that's not a scientific way of doing it, in the sense that ideally you should be checking at T cell receptor occupancy, right? And therefore decide at what point in time you lose that. I mean, there was a trial of nivolumab, continuous versus interruption, and you know that interruption is not good. But then when you get into a situation where patients can't afford every 3 weekly dosing, I think every 6 weekly, every 12 weekly, we don't know what is the appropriate time interval. But looking at it, that is something which I do most of the time.
So I have a question regarding a very practical situation that we face for osimertinib. It's a very costly drug, even not affordable for majority of the people, and we have cheaper substitutes from other countries. So what is your experience with those osimertinib and
So that's what I said. So the student thesis which we have, so we can actually check osimertinib blood levels.
Okay.
We can check osimertinib levels, and I mean, doesn't matter where the osimertinib is from, as long as it has osimertinib. I mean, in India we don't use, the trial we did was with original osimertinib, but even there, alternate day actually gives you decent blood levels. Right?
And choosing between like a substitute of osimertinib versus gefitinib or something, what would you choose? Like one is from a branded company or a approved drug, and versus osimertinib from not the one which is.
It's not about. I mean, OC versus gefitinib is the question.
Correct. Because of the cost constraints, you can have a cheaper.
So if you are in the adjuvant space, the data with gefitinib is not that great.
No,
right?
for the metastatic.
Yeah. So if you are in a metastatic stage, we do have trials where if you can ensure that you give a good treatment upfront and at progression you bring osimertinib. So you I think the trial was called Apple or something. It was a little old trial, but the overall survival doesn't differ
because,
much.
Sir was suggesting that use your best drug first rather than
True. So you could say that chemo plus gefitinib is not a bad option, as long as you can ensure that there's no drop off and you don't lose the patient, and you probably can expose him to osimertinib later
on.
It's not the best strategy, but if you can't afford it, then what else to do? Okay, thank you.
Thank you.
Thank you, Ashish sir, and all the panelists for such a comprehensive discussion. Now we move to our next talk on an important and practical question in thoracic oncology. Is osimertinib alone sufficient for first-line advanced EGFR positive non-small cell lung cancer? To deliver this, I invite Dr. Ghanshyam Biswas, consultant medical oncologist, Sparsh Hospital, Bhubaneswar, to stage. We welcome you, sir.
So very good morning and thank you organizers. So is osimertinib alone sufficient for the first line EGFR mutated advanced NSCLC? Today we know that in advanced non-small cell lung cancer, all road leads to NGS. So coming to genomics of lung cancer drivers, so by this time we have been with the metastatic disease, especially adenocarcinoma. But what's happening in early stage? That we need to do a PD-L1, ALK and EGFR because we have already an approved drug in this space. So EGFR mutated lung cancer overview. So around 20 to 40% of EGFR mutated. So more in the Asian versus non-Asians. If you see the Indian context, so somewhere it ranges between 20 to 40%. So EGFR mutations are located in the tyrosine kinase domain, and we know that the most common EGFR mutations are deletion in exon 19 followed by exon 21 L858R point mutations. So in the EGFR mutated NSCLC development in last 2 decades from 2003 to 2025, so we are almost a decade of osimertinib. So 2015 osimertinib came in to T790M with AURA, and we are at this time with the FLAURA. So by this time, then osimertinib as a first line. So overview of the first, second and third generation of EGFR TKI in terms of the reversibility and irreversible in terms of response to T790M. The treatment evolution in EGFR mutated non-small cell lung cancer, so we have come a long way in last 1.5 decades. So from moving from base supportive care to chemotherapy to now, from 2000 onwards, we are looking at the targeted therapies. So if you look at the busy slide of using alone a TKI from first generation, second generation and TK and the third generation, so what we achieved in this winner ladder, that we have doubled the response rates, we have doubled the PFS, but we are struggling for the OS. So if you see the PFS, so there was a benefit, and if you see the OS till some time back when FLAURA showed that, so there is a benefit in terms of overall survival. So it took a long time to improve the OS in this space. So despite PFS benefits with EGFR TKIs of first generation and second generation, so OS improvement was not demonstrated until FLAURA, the first trial to show a significant OS benefit in the EGFR mutated non-small cell lung cancer. So alone is not sufficient for me. So a decade old, so notable phase 3 studies, so AURA3, so all these 5 got published in NEGM. So AURA3 2017, FLAURA again 2017, ADAURA in the adjuvant space 2020, and FLAURA 2 2023, and so LAURA 2024, and so on. So journey from AURA to LAURA, and so as we see our Prime Minister, so osimertinib, FLAURA has been the standard of care for more than 5 years when it was compared with the first generation TKI. So we have improved the ORR, we have improved the PFS and the OS, and especially for diseases like EGFR, where CNS sanctuary is more common, so we have also taken care of the CNS metastasis. So why the need of combinations? If you compare osimertinib with the other generations, so very few patients remain on therapy after 2 years. Need to further improve outcomes in EGFR patients. Very few patients have a 5-year OS, highlighting the need for better first-line options. So today we have achieved a lot with ALK TKI, but the same thing was not replicated with the EGFR TKI. So the initial trials of combinations, including the own ALMA trial of TMH and the NEG09, so we started adding chemotherapy with a first generation TKI versus the TKI. So now you can see, so we have achieved an overall responses, PFS and OS. So together we achieve more. So will addition of chemotherapy to EGFR TKI help improve outcomes? So on one side the NEG009 and the TMH study, So we have improved the PFS, and probably we'll be achieving an OS. So studies have shown that the addition of chemotherapy to TKI can improve outcomes, further delay treatment resistance and disease progression. So the newer trials are the FLORA-2 and the Mariposa, and the combination. So probably one was not enough, and so doublet can do better. So we don't know if the third one also can do much better. So FLORA-2 design was for newly diagnosed treatment-naive patients where osimertinib was combined with chemotherapy, and on maintenance, we continued the osimertinib and pemetrexed with the primary endpoint being PFS and rest being the secondary endpoints. So this trial had 40% of the patients with CNS metastasis at baseline. So we can see, so investigator assessed and the BICR, so both have a significant hazard ratios with a quantum of benefit for more than 9 months. So OSI plus chemotherapy showed a statistically significant and clinically meaningful improvement in PFS versus osimertinib monotherapy. So all PFS benefits was consistent across all predefined subgroups with osimertinib and chemotherapy. So you can see here, even exon 19 deletion and L858R, which is supposed to be a bad EGFR alteration, so you can see, so the hazard ratio was still holding good in both the situations of exon 19 deletion and L858R. So a consistent PFS benefit with the combination of OSI and chemotherapy was seen in both these types. So high proportion of complete responses in the CNS, so around 50% in the combination arm. So TP53 is known as a poor prognostic factor, but the combination showed that, so in spite of a T53, so this combination is doing good. So what about extrathoracic metastasis, liver metastasis, which is supposed to be a poor prognostic factor? Again, so this has been counteracted by the combination of this. What about bone mets? Again, so there was a benefit of this combination in the subset of bone metastasis. What about high tumor burden? So more than 3 metastatic sites versus less than 3. Again, so this combination has fared well. So overall survival data, so you can see, so OSI plus chemotherapy almost reaching 48 months versus osimertinib monotherapy at 37 months. So the quantum of benefit around 10 months, if you see at 3 years, 51 versus 63, at 4 years, 41 versus 49. So initial toxicity when PEM and platinum was there, so probably you will see an toxicity. Once the platinum is off, so probably the toxicity is much more manageable. So for follow-up safety analysis, so now comes a Mariposa, which is amivantamab, the bispecific antibody with the largetinib versus osimertinib, again in a treatment-naive population. So this shows the primary endpoint was met of hazards of 0.70 and the delta of benefit was 7.1 months. And what about EGFR 19 and L858R? So both these subsets were benefited with the combination. So if you see both the trials together, so though you may not be able to compare because there are not an head-to-head trials, but if you see the FLORA-2, so 9.5 versus Mariposa for 7.1 months. If with the CNS efficacy in a FLORA for 0.47, hazards of 0.79 in the Mariposa. So overall survival across subgroups, so again, so there is a benefit. Safety analysis, so this regimen is toxic, but there are certain trials like Cocoon, so where, so these have shown. An Asian expert perspective of the first line, where even our own Dr. Akhil Kapoor was there. So that showed that expert perspective from Asia on use of the combination treatment regimen. So majority, that is 54% experts believe to use the combination therapy in first line EGFR mutated lung space. However, those who would not want to use in selected subgroups have identified their choices for both regimens. And this can be because of the CNS metastasis, L858R mutations, which is as compared to exon 19 deletion is a bad, liver metastasis, bone metastasis, or presence of a co-mutations like P53, high tumor burden, and a good performance status, young patients. So probably these are conditions, situations where probably you are going to add both chemo and the TKI. So this was a slide borrowed from one of the interest speaker. So nearly all EGFR patients have some of the risk factors. So risk factors can be into 6. So age more than 65, EGFR L858 versus 19 deletion, performance status good versus bad, brain metastasis absence or presence, liver metastasis absence or presence, or TP53 co-mutations absence or presence. So these are, how do you choose between these? So safety and tolerability, so Mariposa and Flora2, the cost and availability, and so on. So these are the guidelines, recommendations from the NCCN. And to summarize, combination treatment like Flora2 and Mariposa has shown a PFS and also an OS benefit. And so today is 21st of September 2025, and this was the same place 21st of September 2024 when the McVie Bernoussi Award lecture was given by the legend Dr. Anita Borges, and the same, and she said, so TMH an enabling institution that makes you walk, talk, and humbles you well behind. So one of the last reports signed by the legend from my hospital, you can see the date of 16th of September, signed by Dr. Anita Borges. So tribute to Dr. Anita Borges, a great teacher who died while teaching, like our ex-president Abdul Kalam, a great pathologist and oncopathologist, a great colleague, and a great human overall, because I was trained at Tata Memorial Hospital when Madam was the faculty. Bhavini Shraddhanjali to Madam. Can I request the crowd to have a 1-minute silence for this great teacher? So thank you so much, and I thank Dr. Bhavna, Dr. Yashwant, and the whole Balco team for this phenomenal job. Thank you so much.
Thank you, sir, for sharing your insights on this evolving field. The floor is open for questions. If there are no questions, we move to our next session. Our next session addresses a key issue in routine lung cancer practice. What is the current standard of care for non-small cell lung cancer driven mutation negative? This will be delivered by Dr. Nitesh Rohatagi, Senior Director, Medical Oncology at Fortis Memorial Research Institute, Gurugram. We welcome you, sir.
Thank you very much, and thank you, Bhavna, and the entire Balco team for always organizing a fantastic session. The topic is essentially about non-small cell lung cancer, non-mutation driven, which basically means immunotherapy. I think Riaz said something very nicely, and I stand by that lung cancer, do your best treatment first. And this is metastatic lung cancer, do your best treatment first, because you'll rarely get a chance to do anything else. Okay, so I'll go quickly. This is there a timer somewhere? There, okay. 15 minutes, okay, I thought it was 25, but anyway, so essentially this is the schema today where you check a patient with PD-L1. If there's nothing else, just know this. If it's more than 50%, it's metastatic, and you feel that the patient will manage with single agent immunotherapy, do that. We'll discuss briefly what that means. If not, it's chemoimmunotherapy and chemoimmunotherapy and chemoimmunotherapy. Okay, so very important to rule out the EGFR, ALK, ROS, BRAF, NTRK, and other fusions. Maybe now, as we are seeing, maybe ERBB2 will join. MET has not joined, but may join. For first line driver treatment, everybody else needs to be classified into PD-L1 high, moderate and low maybe, but certainly more than 50%, less than 50%. Extent of tumor, extremely important. Multiple organ involvement, pericrisis, already severely symptomatic. These are not patients you want to challenge with single agent immunotherapy. And equally important is squamous versus non-squamous, because we do know squamous do poorly, and there is somewhat of a difference there. But just let's pick up the more than 50%, and there's some landmark outcomes already for the key trials like the 024. And you saw a big separation of curve, and this actually set the stage for immunotherapy versus chemotherapy in PD-L1 more than 50%. But do note that when there is a PFS curve, there is, I don't know if there is, if you note, there is actually the curves are joining each other in the first 3 months, which is why I said if somebody is in crisis, if they have multiple organ involvement, if they are symptomatic, especially severely, even if PD-L1 is more than 50% and you think single agent immunotherapy is the solution, do not start with that, because there is a fallen curve initially. Again, most of the patients on this trial, almost the entire lot, were PS01, and my guess is many of the patients who are presenting with severe symptoms at least are not PS0 So you have to be careful when you're choosing single agent immunotherapy in this group. Having said that, even the chemo-immuno arm, most of them was PS01. This is the other drug which is not available, ipilimumab, but again it is an option for single agent immunotherapy and showed the similar benefit. What this trial very interestingly showed, and that's why I put this trial up, is that as the PD-L1 goes up, possibly the responses do go up. So if you do have a PD-L1 more than 90%, your response rates are likely to be better. But do remember, I showed you the curve initially, the combination arm, the PFS, the curves are joined, they drop steeply. So I would still not use immuno alone at a PD-L1 90% in an adenocarcinoma or squam if the patient is symptomatic, high volume and multiple organ involvement. Unfortunately, the PD-L1 alone, atezolizumab versus platinum, IMpower 110, did not show that level of benefit we were expecting, although there was a numerical benefit, but the survival curves met. Coming to non-squam adenocarcinoma, PD-L1 irrespective, whether it is more than 51, 49 or less than 1%. And there are lots of studies, but this study set the stage 189. Again, look at the performance status. And we had an intention to treat analysis showing a clear benefit with the hazard ratio of 0.60. But also we had a group of less than PD-L1 1%. This is the group with no PD-L1, which showed an overall survival benefit with the hazard ratio of 0.55. So it almost became that if you do not even test, or if there is no tissue and you can't do PD-L1 testing, as long as you're sure that the EGFR and your targets are negative, and I'm saying that again, as long as you're sure that the patient is target negative, so spend time and effort there, you can go ahead with chemoimmunotherapy. Checkmate 9LA, I felt this was a very interesting trial. There was a 4-year update as a paper and then a 5-year update only as a poster. But the long and short of it was that the intention to treat again did show benefit, although it seemed like the hazard ratio is slightly less than with pembrolizumab, but there was clear benefit. The PD-L1 also showed benefit, but the key uptake of this was that there was a 22% patients at PD-L1 less than 1%. So chemoimmunotherapy with 2 drugs, PD-1 inhibitor and CTLA-4, Nivo and Ipi, along with 2 cycles of chemotherapy. At 5 years, 22% patient was still alive, and that is as compared to almost 10% with pembrolizumab. So I think this was the most telling part of Checkmate 9LA, that if you have a PD-L1 which is extremely low, less than 1%, this combination seemed to do something to the group of patients, and we'll just discuss briefly what it may be doing. But before that, atezo plus chemotherapy first line, and as I said, although this was a PFS benefit, but when you look at a co-primary endpoint, which was overall survival, it failed to show benefit. So that brought to the point that why the difference, and it seems that when we use PD-1 inhibitors, we are blocking both PD-L1 and PD-L2 interaction with the PD-1. And that complete inhibition may be the reason why it's more effective or maybe even more immune toxic. But when we're using PD-L1 inhibitor, we are in fact leaving the PD-L2 behind, which may be the reason why it's slightly less effective, maybe less toxic, but gives the flexibility of a CTLA-4 therapy to be added to this. The tislelizumab is the new drug on the block. It is cheaper, it is more easily affordable by a population, and we have Rational 304 and 307 in adeno and squam respectively, again showing a good benefit in PFS and in OS. But do know that in the OS the benefit seemed to span out, the confidence interval crossed to 1, and maybe the reason for this, which has been that there was a massive crossover, there was a smaller sample size, OS was secondary and underpowered, it was heterogeneous by the, we'll see that by the PD-L1, but really when you adjusted for the crossover, the OS did suggest somewhat benefit. So you could argue that that's a benefit, but well, Pembro also had a big crossover, has been an argument, because the Pembro had a crossover of 55% versus Rational to 52%. So we really don't know, but we do think that there is a benefit of the drug, and it is cheaper, so it is certainly worth considering. And I think I'll bring it to Ashish's point that if I had to choose between a lower dose and a drug which is proven to have a track record, I would choose cost to cost, I would choose the drug which is being randomized and studied, at least in some part of the world. This is Toripalimab, choice 1, phase 3, again all comers. This also showed benefit when it was all comers, but it was a bit of a confusing trial because the primary endpoint was actually PFS and the crossover was far less limited, and yet the numbers are supposed to be comparable, but I don't think they are. In non-squamous, yes, the benefit was seen, but in squamous I'll show there was not. And interestingly, the more than 50 and less than 1, it was not as significant as the 1 to 49. So it's important to note these small caveats and differences before we conclude and use that for our patient. Very interesting study combination, again IO, durvalumab with TREM, Poseidon, I think that's what we call it. This in fact again showed that when chemo IO is used with double immunotherapy, there is a hazard ratio 0.77 and a P which is 0.03. So there was a benefit, but this was only when TREM was added to Durva. So again showing that a PD-L1 inhibitor, again like Atezo or Durva, may not be adding as much value unless you add the second CTLA-4 inhibitor here. And that may be because there is a synergy with the chemotherapy, because the chemo releases tumor antigens and the CTLA-4 blockade causes an enhanced priming, or it may be a subgroup effect, we don't know, but I do believe it is a synergy of CTLA-4. If I had to choose, I would actually still use pembrolizumab, cost being equal. It has high crossover and yet showed OS benefit in a very well controlled randomized trial. So to my mind, it remains standard of care. All the other options, I'm not denying that, and I think Rational is a very important option, at least for us, with a cost maybe at least half of possibly the cheapest pembrolizumab in the world is in India, and this may be still half of that. But what about squam? And there's worse group, worse outcomes, but not very different when we talk about immunotherapy. The Keynote 407, as we know, also showed intention treat analysis in the whole group. But the benefit, as you see, the curves are merging somewhere in between in the more than 50 and less than 1. And surprisingly, 1 to 49, there is a better separation. These are smaller, these are subgroups, so we can't take them as seriously. And coming back to Rational, again, we saw benefit with both the NAV and the paclitaxel, but really the clear benefit came when we took the crossover effect out. So it is a useful drug, as I said again, for our population especially because the cost is better, but we have to decide based on cost more than anything else because Pembro clearly is the winner there. This is essentially to show that the R7307 showed benefit across all PD-L1, while the Keynote 407 not in less than 1. So again, if I have a squam in less than 1, now that I have a choice, I may actually consider R307 as an option. Coming back to toripalimab, squam did not show benefit, so be careful on that, and again be very careful on PD-L1 more than 50 and less than 1. Atezo small squam again was not much benefit, so I would go with Keynote if possible, all coming back to rationale if not. Some very unique features, and I think this was interesting. Why these differences are there is because although Pembro is a classical IgG4 PD-1 antibody, it's got huge backbone and global data. Tislelizumab is engineered to be in FC region and therefore minimizes macrophage, while toripalimab is a PD-1 binding of epitome, which basically is trying to fight the resistance we are seeing with the older or standard immunotherapies, and whether we will see that or not, I think time will tell. Durvalumab was engineered for IG1 rather than IG4, and same way with avelumab, which is specific, retains the wild type IG1. So there are some resistance, and a lot of work is going on if we can pick up patients who will be inherently resistant or develop resistance, and with a change of immunotherapy focusing at the mechanism of action help. While this was about non-small cell lung cancer, non-driver mutation, I think it's all mostly first line. When you really think about second line, I'll say this again, very few patients really reach second line enough to clearly benefit. They do get the second line therapy, but the benefit is a big question because the PS has dropped, the volume of disease is high, toxicities have gone up already because of previous treatments. But docetaxel, pemetrexed, gem remain standard chemo options, and in chemo IO, nintedanib and ramucirumab have standard second line option. However, I think this is interesting. There are some Varagdo study, which was basically a prospective observational study. They did not really do any intervention. They were observing what doctors would do, and where chemo followed by IO was used, and then docetaxel and nintedanib was used, there was actually a better overall response rate than when chemo IO was used up front. That's not a reason not to use that, it's just an observation, but really what it means is that you can consider a combination of taxane and nintedanib, and there is a lot more happening, and I think that's really what we are waiting for. We are waiting for IO with more immunogenic chemotherapy. We are certainly waiting for the new novel immunotherapy agents which will target better, and the cytokine target, and I think that will show a very big change in the next 3 to 5 years to come. Combination of ramucirumab and pembro S1800 is very interesting. There was already some 14 to 15, about 3 to 4 months overall survival difference. That's not bad for this category of patients. And of course, we are all waiting for the big ADC, especially the data being used after the Tropion-Lung1 trial results. Immunotherapy backbone, this is my quick summary slides. Immunotherapy backbone remains standard for PD-L1 immuno alone, provided the patient is right. For less and for everybody, it's chemo IO. Chemo IO combination OS, key 189 to my mind remains the best drug. In squam as well, pembro remains the best drug with the strength of data and now experience. But please do not forget that other therapy options are real, effective, although they may not have crossed the benchmark of statistical benefit. Dual checkpoints are very interesting. Please do consider them, especially when the PD-L1 is less than 1 and some other selected indications. The biological lessons are important, especially when it comes to resistance. I think we'll see more and more of that information arrive. Crossover effects are real, so please again look back at data if you need to use, especially a lower cost immunotherapy, because I do believe that these drugs are effective and I've used them personally. But the practical framework, my last slide, treat with best option first line is always better. PD-L1 more than 15, non-squam or squam, it is IO if the patient can take it, depending on burden and the speed of symptoms. PD-L1 149 for everyone, squam, high burden, again I'm saying that in PD-L1 less than 1, do consider dual IO. If a patient is unfit for IO for any reason, has autoimmune condition, do not forget that the chemo with PEM and carbo and PEM maintenance did very well in Paramount, and it was the base on which everything seems to be based. And please do not forget that the chemotherapy is still there for you. Thank you.
Thank you, sir, for such a comprehensive update.
Not able to afford for Pembro now. And
so I think your question is PD-1 interchangeable with the other generic PD-1? Yes. To my mind, they are not interchangeable, and I was trying to say that. I think the strength of data and now experience is clearly higher with pembrolizumab. But if a patient can't afford, will I very confidently use the 2-3 new drugs I have? I will, and I have. And I do think that
So interchangeable.
If the cost is an issue, yes. In statistical answer, no. In academia, no. In confidence, no. But cost and issue,
Sir,
yes.
Among these three, Serplulimab, Tori and Tisli.
Yeah. So Tisli seems to be slightly more effective as a drug here, especially when it comes to adenocarcinoma. I think Tori is only effective there. So if it comes to squam, I would use only Tisli. If it comes to adeno, I could use Tori as well. I think cost-wise, there's not much difference there, or at least there will be a cost fight happening in the next year or two, so we'll know better. But I do feel that Tisli is a very effective drug here.
Thank you, sir.
Sir, excellent presentation, sir. So I just wanted to know your opinion on your experience with dual IO, like the Checkmate 9LA, because it definitely gives the patient an opportunity to stop chemo at some point, which in the longer run. How do you feel?
I personally am fond of it actually.
Yeah, we've heard.
I have used it, in fact, a number of times. I like it when I have a patient who's symptomatic and I feel will not tolerate chemotherapy for very long. Borderline kidney function is an example. The first time I got attracted was a diabetic patient who had kind of brittle kidney function. You know, there was between 0.8 and 1.3. These are patients who I was struggling with and was symptomatic. But I think as we read the less than 1%, it is very compelling to use that over and above everything else. And I think the fact that 22% patients were well is again very compelling. I don't think we can ignore 9LA at all. Yes. We have got used to first night 189 and 407 because it's now on our pen and we think intuitively. But I think it is a point to consider.
So you didn't find the initial 4 doses of EP to be too tough to give?
Actually, 4 doses of PEM and carbo are not tough. The problem is when you come to squams. 4 doses of taxane platinum can get tough for some patients. So, but I don't think that alone should be the choice, because do remember that both our experience and the data is strongest on 407. But as I said, I do think, yeah, it's certainly a consideration.
Sir, I would just beg to disagree a little bit on the dual checkpoint blockade. See, in a patient who has diabetes, brittle diabetes, things like that, when you give dual checkpoint blockade, the likelihood of requiring steroids goes up drastically. Almost 30-40% patients need high-dose steroids to manage immune toxicities. So in a patient who has poorly controlled diabetes, going down the pathway of dual checkpoint blockade actually puts you at
I'll accept what you're saying.
That is one thing.
I'll accept. So let's go one by one then. So I'll accept what you're saying.
Just one more point.
So we'll go 1 point at a time. I'll accept what you're saying, and that is a problem, but I personally don't see as much toxicity. As do remember that in India we are not giving over 50 of EP to almost anybody. We are not going by the weight. So we're not going 70 mg, we're not going 75, we're going 50. At least with that, experience has been good. If you do develop toxicity, yes, of course, you have to manage with steroids, but when we manage steroids, we are physicians, we do know how to manage the diabetes in those patients. The problem is when we do things which are unexpected, when the patient or the teams are unaware. So once you are aware, once the patient is aware, once you are ready for it, I don't see that as a problem.
Second point, coming to the efficacy part of it. ASCO, in its recent living guidelines update on patients without driver alterations, they quoted a trial, the Japanese trial called Nippon trial. So I looked up the trial, this was published a few months ago in Lancet. It's buried because this trial was terminated early. This was the first trial to compare the 9LA regimen versus the Keynote 189 regimen. And the trial had to be terminated early because there were unexpectedly more deaths in the dual immune checkpoint arm, around 7 to 8% deaths in the initial enrollment. But whatever they analyzed the data, there was no difference in survival between the 9LA arm and the 189 arm. And in the subgroup also, the squamous subgroup, PDL1 less than 1% subgroup, there was no difference in the median survival. So yes, it's not powered optimally because the trial had to close down. But the fact that this was...
I think your answer is in your question. So if you pick up a trial with between a randomized phase 3 long-term data, 22% survival is not small for a patient that group versus something broken. I would actually still go for it. I think unless there is a proper randomized study which concludes and is able to prove that point, till that point I'm compelled to deal with what I have. I don't think I'm accepting a study which was terminated before and gave a conclusion as an answer to somewhat a good experience. Maybe I chose my patient differently, or maybe we have a very strong ability to back up, but my experience of a couple of patients with chemo, with dual IO has been good. So I have no objections there.
Right. Thank you.
Okay, thank you very much.
Thank you, sir. In view of travel schedule of Dr. Sherawat sir, we'll be slightly reorganizing this session. So for our next panel, the next panel discussion focuses on SBRT versus surgical resection in early non-small cell lung cancer. I invite our moderator, Dr. Sherawat sir, Head of Radiation Oncology, Bhagwan Mahavir Cancer Hospital and Research Center, Jaipur. Our panelists for this sessions are Dr. Piyush Shukla, Radiation Oncologist, MMI, Hospital Raipur, Dr. Sarthak Tandon, Radiation Oncologist, Rajiv Gandhi Cancer Institute and Research Center, Delhi, Dr. Anita Malik Sirohi, Radiation Oncologist, Venkateshwar Hospital, Delhi, Dr. Sneha Botra, Consultant Medical Oncologist, Mithil Hospital, Raipur, Dr. Preeti Agarwal, Consultant Medical Oncologist, Jaipur Health City, Jaipur, Dr. Sriniket Raghavan, Consultant Surgical Oncologist, Max Healthcare, Delhi, Dr. Mohan Venkatesh Pule sir, Thoracic Surgeon, Medanta Medicity, Gurugram, Dr. Saurabh Jain sir, Consultant Surgical Oncologist, American Institute of Oncology, Raipur.
So, I welcome you all to this session. Good morning, everyone. I think there has been some change in the list of panelists, but anyway, we will be able to do with that. So, this was the original list of surgical oncologists, medical oncologists and radiation oncologists. Okay. So, quite a lot of change. So anyway, my first question is to the surgical oncologist over here. If you see a lesion like this, any of these two, what is the first thing that comes to your mind? So I am asking our surgical oncologist colleagues to answer one by one. And how will you proceed?
So it's a peripherally located tumor, but it is quite close to the visceral pleura, and easily it's a irregular lesion, and I would go for a biopsy, and then preferably either a PET-CT CT or a CT abdomen, pelvis and chest.
Okay. Any other view of a second surgical oncologist? We have only one surgeon? Yeah, please.
So, broadly I would agree, just that it looks like a malignancy, though the overall appearance is not very typical. It's not a speculated appearance, and so we'll look at all the relevant imaging, look at mediastinal nodes, take a smoking history, look for any other possible etiologies, but broadly we would try to confirm it with some form of tissue diagnosis, CT guided biopsy, bronchoscopy with BAL if we are suspecting that there could be an infective etiology, and depending on the biopsy reports, then proceed with the further if further imaging is required.
What is the age of the patient, if you can?
75.
75, and any comorbidities or
all you consider all comorbidities not to be there. We just have a simple case like this, and we have to proceed.
So I agree with the previous speakers, whatever they have said. It's definitely a malignancy should be kept in the differential diagnosis in this case. Elderly male, probably a smoker. So first biopsy it, prove its malignancy, stage the disease, assess the biomarker status, and of course stage the mediastinum as well in this case especially.
Okay. So radiation oncologist Dr. Sarthak, any viewpoint which is slightly different from?
Nothing specifically different, but also I would like to have probably a prelim check on the lung functions, because that's going to happen.
Sorry?
That's all, lung functions and lung function tests, and what are the
lung function
the assessment regarding the any comorbidity or any substance abuse, because that's also going to direct my biopsies and also help me direct my management accordingly. So probably that could add on to my. Other than that, it's a peripheral tumor which needs to be biopsied before we go anywhere ahead.
Dr. Anita?
So we will discuss this case in our tumor board after all staging and workup. We'll discuss whether to operate or radiate this patient. So peripheral tumor, both are the options, surgery and SBRT.
Okay.
And if patient is fit, lung functions are good, so we can offer both the things to the patient.
Okay. So I want to ask my medical oncologist, would it make any difference if this is a adenocarcinoma or a squamous cell carcinoma or a small cell carcinoma? In this particular case, would you like to differentiate between all the three?
Yes, it is important to differentiate between whether it is small cell or non-small cell. Yes, it is important, and it will help us in prognosticating and differentiating the treatment as well. And it is important to, yes, we will biopsy the lesion and we will distinguish, and we will do the markers as well.
So if this comes as a small cell carcinoma, how would you manage differently?
So very early stage small cell lung cancer, it's very, very rare to find. Extremely rare to find. If it is a small cell lung cancer, I have to do MRI brain, we'll do the PET scan, we'll find out whether the disease is anywhere else or not. And then surgery versus radiation therapy, in a 75-year-old, it is, I would rather go for a radiation therapy in a 75-year-old rather than going for surgery in a small cell lung cancer.
Okay. Would you like to, our second medical oncologist, would you like to do moleculars at this level? Whether it is small cell or non-small cell, whatever.
So small cell, non-small cell has to be different.
If it is a non-small cell, would you like to, if you are advising a biopsy, true cut needle biopsy, would you like to order these also as a reflex or?
So at the reflex, I don't think we need the markers, because if we are deciding surgery versus radiation, we don't need it. But we can keep it as a backup for the further treatment options. And if the patient cannot tolerate surgery or radiation, then molecular markers would help if it's adenocarcinoma.
So you want to keep that for reserve. Maybe after 2 years, if the patient has a relapse, that can
be taken care of.
So I want to ask you, the finding of molecular markers which you obtained right now, would that be validated or appropriate after 2 years?
So after 2 years, I would rather re-biopsy and do the markers then.
I will differ, sir. I will do EGFR, ALK if it is a non-small cell lung cancer, and PD-L1. There has been therapies which we, if it is a stage 1B or more, we will in an operable lung cancer also we give neoadjuvant therapy. Not in the 75-year-old if there are other comorbidities, but stage 1B or more, then yes, immunotherapy. If it is EGFR or ALK, we would like to give adjuvant therapies as well. Yes, I would like to go for a molecular markers as well.
So any other panelists, if we are considering this case for either resection or SBRT, would you encourage this molecular at this level?
So specifically speaking in regards to SBRT, I mean I obviously keep the decision regarding systemic therapy to medical oncology, but there are few data which suggest that post SBRTs, if you go for systemic lines for patients who are at risk of early relapse, especially doing a ctDNA, they can probably benefit out of systemic therapies. And if you know the molecular markers, I would suggest if for patients who are at high risk of relapse, probably doing a molecular way is adequate.
Any other viewpoint?
So we haven't staged the mediastinum yet in this patient. We have not even seen that. So I think that is very important to first know, because we are just looking at the peripheral lesion. We are just looking at the CT. We need to know the mediastinum. This patient may have N2 or N3 nodes, and then I think our answers will change probably, and we will not have that discussion on resection versus SBRT, and we'll probably consult this with our medical oncology colleagues. So I think the first step would be to stage the mediastinum as well as the correct staging of the patient.
So I'll have a small differing opinion here. It is definitely true that we go for a CT guided biopsy. Most of the time a decent histopathologist would at least be very clear whether it is small cell or non-small cell lung carcinoma. We can keep the slide and blocks ready for doing the molecular workup at a future date, and that future date need not necessarily be 2 years or 3 years down the line. So let's say that we evaluate the curative options for this patient. If this patient is going to be a surgical candidate, then we are going to get all of the tissue outside, and we are going to have a lot more tissue to look at all the possible molecular markers, whatever we want to dance around with. And if it's not going to happen by any chance, then we can revisit the decision a couple or weeks back, and then with a discussion with the medical oncologist actually decide. And another perspective, particularly because there are people here who are from high volume institutes like Rajiv Gandhi and people who have worked in places like Tata, it's a good idea to do at least the basic molecular markers, the EGFRs, the ALKs, the ROSs, just to have a look at what is the patient profile, because we need that sort of data also, because most of our decisions are directed by usually Western or Far East data. So it's a good idea to do at least a basic panel for most of our patients, unless it's a financial consideration.
Okay. So I want to ask our medical oncologist colleagues whether you would be okay with just an FNAC or
no, I would like to go for a true cut biopsy.
Definitely you will go for a biopsy so that you can perform all the... So, radiation oncologist, would you go for a contrast enhanced CT scan, or you want to have a 18 FDG PET in this?
So the imaging would be not just for the local but also for the mediastinum, so it definitely has to be a PET scan. Also along with the other measures to address mediastinum, but then yes, I would like to go for a PET scan, a functional imaging.
Dr. Anita?
T2 onwards, I think PET scan is must. For a very small lesion, T1, chest CT is enough.
Because you would be comfortable with just
risk of metastasis in T1 is tune of less than 5%.
Okay. What about our surgeons?
I think we should go ahead with the PET CT, because the availability of the PET scan is more and more increasing, and the more centers are actually doing the PET CT. And if we compare in terms of the cost also, the CECT of the chest, abdomen, pelvis, combined all of them, if you compare with the PET CT, I think we are not maybe few thousands different between the two.
Okay. So I would look at it this way, that like getting to know whether the nodes are positive or negative just on CCT needs a very experienced radiologist, and if you are missing that and you are inadvertently operating on an N2 or an N3 disease just on CCT would be very futile. I can actually, the surgery may not be the right option for that patient, and I think choosing PET at this time, even in constraints, I think is going to make a lot of difference. So I would definitely go for it.
I'll just say that I don't think not doing a PET CT scan should be considered a viable option unless it's like a very outlier case for some logistical reason. Yes. Simply because there is a trial which says that other than having a mass which is less than 3 centimeter and peripheral, in which the positive predictive value of a CT scan is, the negative predictive value is very low, it is in the single digits. That is the only scenario in which imaging N0 will match with a histopathological N0. Every other case, either a central tumor which may be T1 or it may look like N0 but it is a bigger than T1 lesion. In every other case, there is a double-digit chance of having subclinical nodes in the mediastinum which are not caught by a CT scan. So in all these other scenarios, a PET scan is what is going to help you. Whether you do the question would rather be whether you would do an invasive or non-invasive mediastinal staging, and even for getting to that decision is where you need your PET CT. That you may think whether I should do or not, but in today's day and age with reasonable ubiquitous availability of PET CT scan, it is for a disease like lung cancer, the compromise should not happen at that point.
Yeah, I second that, and also probably if I want to take a case from a surgical oncology colleague, I need to prove that the mediastinum is completely free, and I need to add an EBUS EOS for that. And the data suggests that if you do the trial, only then you're 95% sure that you have a completely clear mediastinum. So PET scan.
So I am getting a feel that we should go in for moleculars upfront for futuristic options, and we should also be in favor of PET CT scan. That is the general consensus right now. So now we have either N0 or N1 on imaging. So what is the role of mediastinoscopy in this?
So mediastinoscopy has major 3 roles in the present era of where EBUS has actually almost replaced the mediastinoscopy. I mean, many people won't agree with me, but however, with the advent of the techniques and the pulmonologists who are getting more and more experienced, the negative predictive value of the false negative rates of the EBUS are actually coming very, very much down. So the mediastinoscopy in our present day-to-day scenarios, we use it in three situations. Number one, where the possibility of N2 is higher, even they are becoming negative in the EBUS, like very small nodes, like less than 5 millimeter. We know that EBUS has less sensitivity in small sized lymph nodes. So it cannot, you actually cannot take the sample from those small lymph nodes. So that's where the possibility of negativity is higher. That's number one situation. Second, the occult N2 positivity situation is higher, like central tumors, high avidity tumors, and N1 positive tumors. But however, the PET CT is showing negative N2, negative mediastinum, where the occultness is a very high possibility. In those situations, mediastinoscopy is a possibility. Okay. And third scenario is, of course, restaging. If you are restaging the mediastinum, where the EBUS sensitivity is lesser. In those cases. And the fourth important scenario, you have a pulmonologist who is initially starting his career in his EBUS. In those situations, the technical expertise to sample those lymph nodes is lesser. So actually, if the technical issue will convert the positivity to negativity. So these are the situations where mediastinoscopy has a role.
Fine. So again, I am asking you the same question. If he was a 75-year-old with COPD and this lesion was there, so, and if the patient comes to a surgical oncologist first, how would you approach or counsel the patient?
So, 75-year-old COPD completely depend. Two things are important here. If we are going to offer both surgery as well as SBRT, first of all, we have to talk to the patient that do they actually want to undergo surgery. We have to explain the risks that are associated with surgery. Finally, it involves either VATS or a robotic surgery, or sometimes even open, with the consent that it may be an open surgery as well. So there is morbidity associated, prolonged recovery associated. Some patients will be they will have COPD, but they may be healthy in other aspects. So it's a good chance that they will recover. But they may be like a frail 75-year-old person who's not willing to tolerate.
So here I want to ask you one question, an honest answer. If he is a 75-year, no comorbidities, he comes to you, T1 lesion, do you even suggest him option of SBRT?
Absolutely.
Okay.
I have done lobectomies for 83-year-old VATs, which I was regretting for the entire period that the chest was open. Surgery went well, patient went home on day 5, and there have been days in which patient has given, I have seen patients and I have said, no surgery for you, ma'am, please go ahead, I am sending you to the radiation oncologist in my institute.
Okay,
Both
thank
ways
you.
it works.
Thank you. Radiation oncologist, if he comes to you first, would you suggest him surgical option also?
No, so
discussing both SBRT?
No. Discussing both options on the table with the patient is is definitely there. You have to discuss both the options. That goes without saying. Obviously, when I am counseling a patient for SBRT versus surgery, I'll be a little biased for SBRT. That goes without saying. But then definitely the discussion needs to be on the table regarding surgical and SBRT, both be it operable and inoperable conditions, especially in these patients.
So I think the question is not here suggesting a specialty, suggesting some treatment to the patient. I think it is the multidisciplinary involvement is the name of the game. I mean, if I am a surgeon, of course my thoughts will be more pro to the surgeon. Radiation oncologist will think that radiation is superior or it will help the patient. I think the factor that decides the treatment is the fitness of this patient, not the radiation oncologist or the surgical oncologist.
I think
age is not a contraindication, and the comorbidities is we have to take it very seriously for deciding any option before. I'll beg to differ here a little bit, because fitness is definitely a question. See, if the patient is unfit, you will never take these patients for surgical options. Yeah, that's definitely there. But the question regarding patients who are fit enough to undergo surgery, would you want to give an option of SBRT to these patients given the certain data sets that we have? I think that's the question we need to discuss. Unfit patients, obviously the only option that is left is surgery.
Yeah, and another thing I want to stress here is, because the fitness of the surgery of the patient should be decided by a surgeon.
Okay, so
that's the point I want to make.
So we have only 1 minute left, so I'm rushing. So how do both the treatments compare in terms of control and survival? Any surgeon?
So I think still the data is better for surgery. All these trials were underpowered. They could not accrue the number of patients that they wanted, and if you go through any guideline, if the patient is fit and operable, I think surgery stands as the first option, and if the patient is medically unfit, then of course you can give them an option of SBRT, but none of the guidelines say that SBRT is the first recommended option for a medically fit patient, because we don't have enough data. You go to any study, they did not have the enough number of patients accrued, or the study was not powered enough to say that both are comparable.
Okay, radiation oncologist?
So just one point, how we talk to patients in this case. If I talk to any patients and I say that you have two options, surgery versus no surgery, then even I won't go for surgery. But we have to tell them that the gold standard for either you're fit or not fit. If you're fit, the gold standard of your treatment is surgery. If after that they said that for X reason, for Y reason, I don't want to undergo surgery, or I am very afraid, I don't have social support, then we say that there is this option which is non-inferior, which is quite good. Please go ahead with that. But I cannot tell them that you have two options, because then nobody wants to have surgery.
Sir, not only the medical fitness, but the location of the tumor is also important. When you are offering a pneumonectomy to a patient, that is a morbid surgery. And when the tumor is peripheral, you can offer both surgery and SBRT. But for the central tumors, offering a very morbid surgery, better to offer CTRT or SBRT, fractionated regimen to the patient. So that is less morbid.
I agree to ma'am that, for example, if it's a central tumor and if even there is a small chance that it could turn into a lobectomy on the left side or a bilobectomy on the right side, even I would say that back off. But at the same time, when at least to my knowledge, when the tumor is quite central, close to the central bronchial tree, close to the major mediastinal vessels, close to the mediastinal pleura, then even SBRT becomes a subpar choice there.
No, no, not now, not now. We can easily do an SBRT for ultracentral tumors touching the mediastinum as well.
Then of course,
yeah,
then I would defer
So
to your experience.
I would suggest to panelists that let us agree to disagree a little bit on some points, and our time is up. So I thank you all, and I conclude this session.
Thank you, sir, and all the panelists for sharing your expertise in this field. Up next, we have a panel discussion on MDT management in small cell lung cancer and rare tumors. To chair this session, I would like to invite Dr. Rudra Pratap sir, consultant bone and soft tissue surgeon at Palco Medical Center, Dr. Dipanjan sir, consultant surgical oncologist, Dr. Krishna Divya sir, consultant medical oncologist, Dr. Prithvi Raj, consultant surgical oncologist, Kim Sunshine Hospital, to chair the session. The panelists for this sessions are Dr. L. Gaurav sir, radiologist at Palco Medical Center, Dr. Sridharan M. sir, surgical oncologist, Manipal Hospital, Goa, Dr. Mansi Kandira ma'am, medical oncologist, Sparsh Hospital, Bangalore. I would like to re-invite Dr. Anita Malik ma'am, radiation oncologist, Venkateshwar Hospital, Delhi, Dr. Piyush Shukla sir, radiation oncologist, NHMMI, Raipur.
Piyush sir is in Indore, and we are, as SBRT workshop is going on, we are short of radiation oncologists. So, sir, Piyush sir, please, in short time, please.
Dr. B. Balakrishna sir, pulmonologist, ILS Hospital, Raipur. Dr. Vivek Tiwari sir, medical oncologist, Gandhi Medical College, Bhopal. Over to you, ma'am.
I don't see the medical oncologists on the stage. Yeah, sir. Dr. Manasi is coming, or Dr. Arindam was here. Please come. Dr.
Also invite Dr. Arindam Mandal, consultant surgical oncologist at Manipal Hospitals, and Dr. Shriniket Raghavan,
Dr.
associate director, surgical oncology at Max Hospital, Delhi, and Dr. Sridhar Raghavan. Sridhar, where is Sridharan?
Sridhar is already here.
Great.
So Dr. Sriniket has been added, and Dr. Manasi, are we waiting for her, or?
Dr. Samir Sri Rangwar sir is there, so sir will be for council. And
Dr. Samir, please welcome
yes,
to the stage.
and I can assure you, Dr. Swaratika, he is equal to 2 medical oncologists.
Otherwise, he's expert in everything, so please. Okay, so I thank all the organizers, and especially Dr. Yashwant and Dr. Bhavna ma'am for giving me this opportunity, and we'll quickly start. Before I start with SCLC, I just like to, say one thing that my mentor Dr. Kumar would love to say, that SCLC is almost like the solid oncologist's lymphoma. Responds very well, but doesn't stay responded for too long, so we just need to figure out the perfect combination on how to treat it. So I'd like to start with, one is that, this thing of SCLC was first diagnosed around 75 years back, and we've not really changed much practice in terms of chemo backbone or the radiation that we've offered since then. And we recently have newer evidences that it may not be a homogeneous disease, with more and more molecular classification and IHC typing and subtyping of SCLC. And we'll discuss a little bit about IO in the era of SCLC, and are we happy with the outcomes, or is more to be desired? So firstly, 71-year-old chronic smoker evaluated for progressive cough and dyspnea. I'd like to ask Dr. Gaurav if he's on the panel, sir. Yeah, could you please comment? We have the CT images as well as the PET images side by side.
Hello? Yeah. Basically, it's a centrally located lesions in the left hilar, parahilar region. It's averting major vessel, probably encasing left main pulmonary artery as well as left main bronchus. And it is infiltrating mediastinal pleura, and along with it we can see some precarinal nodes which are very active in PET CT scan correspondingly. And I don't know about bone lesion because we have to look for the bone lesion for the whole body, but basically it's an active centrally located lesion with involvement of multiple mediastinal vital structures, vessels as well as pleura.
Yes, sir. So, so imaging. So, you know, before we used to do CT versus MRI for the brain, as well as nowadays the standard is FDG PET. So, sir, what are your experiences? Do you advocate FDG PET for all patients with suspected SCLC? Are you happy with CT alone?
No, ma'am. We usually go ahead with PET only. PET CT for the whole body imaging, we do PET CT, as well as for the brain, we do MRI with contrast.
Yes.
We try doing it in the same day, but usually we give a time of 24 hours. Now the guidelines, CT is not that accurate, and as well as small cell carcinoma is a more systemic disease.
Yes, you have nearly a 20% upstaging of disease with PET CT alone. Yeah. You don't want to deprive them of the correct treatment. The radiation oncologist, Dr. Anita. Hi, ma'am. So what are your views? Do you do MRI? Do you insist on MRI for all limited stage SCLCs?
Yes, so T2 beyond T2. T2
beyond
onwards.
T2, you want
onwards. We are doing MRI, contrast MRI.
Contrast MRI. Okay, so for very early, if the PET doesn't show any disease in the brain, you'd like to avoid it?
Yes, for T1, we can avoid.
Okay. So now we come to the histopathology. We've had a biopsy. It came. So I was expecting a pathologist on the panel. So we'll just skip the slide. But we know that 2/3 of SCLCs are actually negative for any cell markers, and 10% are negative for all. And we have newer markers coming up. We'll just skip it for right now. So yeah, now Dr. Arindam, what are your, in your experiences, how many T1s N0s do you see of SCLCs?
So SCLC,
you can include your TMH experiences as well.
And it's very rare. It's very rare.
It's very rare.
It's mostly SCLC. If you are getting a case, it is as good as metastatic. You know, I mean, it is not a surgeon's game basically. But yeah, rarely, like in the last 4 years, I would say I have had one patient. One patient in 4 years, which is like a small 3 centimeter lesion with no mediastinal nodes. Those are miracle cases basically, but otherwise it's mostly very, very rare to find this.
Have you ever, anyone on the panel, it's open for all, has anyone picked up an SCLC on routine screening? For example, we know these are more common in smokers. Smokers have a low-dose CT directed screening programs in many places. A lot of corporate hospitals are offering packages nowadays.
During COVID,
are we picking it up earlier?
So during COVID time, we picked up very early cases, very few.
Very nice.
Yeah, but I don't remember SCLC. NSCLC we did during COVID, but SCLC, that one case which I can think of.
Yeah, so I think the most common thing is despite a T1, T2 lesion, I think 30% of them go on to need some form of adjuvant chemoradiation. We don't want to advocate triple modality. Dr. Sridharan, what has your experience been on this?
Very rare to find a small cell lung cancer with the
So if you could just speak into the mic, I can't hear you actually.
Yeah. So it's very uncommon to pick up a small cell lung cancer. As he said, like small cell lung cancer is a systemic disease until proved otherwise. So even if you find a case which is like T1, T2, you have to be like absolutely sure before you are going to put a knife on that patient, because the patient is going to need chemotherapy anyways. There is no way you can avoid that chemotherapy. RT also, it takes a lot of guts to avoid RT in such cases.
Yes.
Even if you need to have a PET CT, you need to have a contrast MRI, you need to have a E-bus which says that the patient is N0, and if you are doing surgery, there is nothing short of a lobectomy you can do for that patient. There is no role of wedge resection or anything in such small cell lung cancers. And there is no role of mediastinal sampling. You have to go for a total mediastinal clearance in these patients. So you
have to follow it up with RT as well.
We follow it up as a RT as well. So surgery in a small cell lung cancer, you take it with a pinch of salt, like go for CT.
Also in this, one aspect is the PET CT debate which we are having. This is one biopsy, the biopsy report in which I will not do a PET CT even if it is a T1 small lesion. because of the high chance of metastasis, which we know. If it is a NSCLC, that's a different game.
Yeah,
that
definitely.
less T1 lesions, very small
Yes.
peripheral, we can avoid, but not in NSCLC.
Actually, we don't see that often early stage small cell lung cancer, but we do see small cell carcinoma involving esophagus, involving cervix, even have seen small cell carcinoma of thyroid. And they more or less had early stage.
Yeah, so we definitely tend to treat SCLCs of other primaries, other organs like bladder, cervix, very different from how we treat the lung, although most of the data is extrapolated from the lung.
We have to extrapolate the lung
Yes,
data
sir,
and we have to
absolutely.
treat accordingly.
Absolutely. Very good point, sir. So one is, so standard of care in limited stage largely is restricted to definitive chemoradiation. We recently have a trial, the Stimuli trial, which looked at chemoradiation post Nivo-EP maintenance. That was a negative trial, but in the current era, it showed that with chemoradiation, the overall response rates was a whopping 95%, 2-year survival rates of 66%, and a 3-year survival rate of 49% in the placebo arm. So these are very impressive, not bad data for SCLCs. So I just like to ask Dr. Piyush. Dr. Piyush Shukla. Okay. Dr. Anita ma'am, you can only take the question. So I'd just like to ask you, what is your fractionation or what is your dosing schedule? Do you give a hyperfractionated schedule? Are you like hypofractionated 60 gray or 70 gray single day fraction, or are you a hyperfractionated 45 gray hyperfractionated schedule?
So usually 60 gray.
Yeah,
60 gray what we follow, and hypofractionation to very small tumors, peripheral tumors in the form of SBRT, but for CTRT 60 gray conventional fractionation we follow, and for bigger tumors adaptive radiotherapy with reducing volumes and respiratory gating with 4D CT we are giving. So with that technique the toxicities are much less.
Right. So we know that a lot of centers do follow a 45 gray by a hyperfractionated schedule as opposed to the 60 or 65 gray that, I mean, our center follows anywhere between 60 to 70 depending upon the size of the lesion and how much they need to give, and of course the, the comorbidities. Dr. Balkrishna? Dr. Balkrishna is here on the panel. Hi, sir. So before starting therapy, or how do you optimize a patient who obviously is elderly, he has COPD, he's going to require chemotherapy, and he's going to require a fairly large radiation field as well. How do you optimize the patient, sir?
So basically, we'll see the severity of the disease of any of the patient of COPD or ILDs, whatever baseline disease is. So there is a, conventionally we used to see with the physiological evaluation by the help of the spirometry, even impulse oscillometry. At times we go for a DLCO as well in the routine practice. So in that way we can optimize the treatment. We can see the prognostication and further post-treatment evaluation also we can done. So in this way we can evaluate the patient both physiologically, and at times we'll go for a repeat CT scan as well as per the treatment.
Yeah, so repeat CT scan, we won't have that much time for an SCLC to give you so much time to optimize the patient. Everything needs to be done parallelly. So we'll have to start the chemotherapy definitely along with radiation within like the next 2-3 weeks in most cases of limited stage SCLC. So we actually, since the time of diagnosis to the time of treatment is fairly short for most SCLCs. Okay, so Dr. Sameer, sir, you can take the question. Do you prefer concurrent or sequential? We usually start with chemo. How many cycles do you prefer to give, sir, for limited stage?
So sequential only if the patient is not fit for CTRT. So if the patient is fit, always better to go for concurrent chemoradiation. Start radiation as early as possible. Maybe after giving first cycle chemo, start as soon as possible the radiotherapy. 4 to 6, we have enough data. We suggest, I think going up to 6 don't help as much. So 4 cycle is enough. And now with the help of Adriatic trial, we are trying to offer the patient maintenance IO also.
Yeah. Absolutely. So I think 4 to 6, most of them doesn't seem in either the OS nor PFS largely favors 6 cycles. But maybe if you have a very extensive disease, you could consider in some, for example, especially those who've not had a PET CT, you could consider 6 cycles. Otherwise, largely we restrict ourselves to 4 cycles. So these are the newer things which are going. We definitely have the data of durvalumab in Adriatic trial, which we'll discuss in detail. Dr. Vivek Tiwari sir is here. Hi sir. Yes sir. So please, your experiences with maintenance durvalumab. When do you start it? After completion of CTRT, when do you start it? How has been your experience with pneumonitis and how do you monitor for it, sir?
So we know that small cell lung cancers are immunologically cold, so I'm not expecting a very robust response as we see in the non-small cells. But yes, based on this Adriatic data, I do offer durvalumab post CCRT, and it is more or less the tunes of the side effects are more or less as seen in the non-small cells. So it is occasionally tolerable to the patients.
Yes, sir. So not very impressive data, but still it gives us, some maintenance therapy. Dr. Samir, any views on this?
Yeah, miss, I have not given to any lung cancer patient, but we had offered to our cervix cancer patient as off-label use.
Yeah.
Because she was non-metastatic, treated with CTRT. Otherwise, at present not offered to any patient. But definitely would offer.
So I think for LS, correct. So we'll give 4 to 6 cycles, definitely follow it up with a PCI, because if they don't have any brain mets, this patient presented.
Now we have data for maintenance, surveillance with MRI versus PCI. This shows even if you do surveillance with MRI, outcomes are equal to giving prophylactic renal radiation.
Yeah.
But that is not feasible in our setting.
Exactly.
Generally we offer.
So this patient has relapsed within 12 months. What do you prefer? Dr. Vivek, sir, you can take the question. Second line, what do you prefer? Re-challenging platinum or switching to something else like a taxane or a topotecan?
So what is the duration that he's relapsed?
So 12 months, sir.
So yeah, re-challenge would be an option. Re-challenge would be an option.
Re-challenge, yeah. So I think I would also, Dr. Samir, do you beg to differ? We can see subgroups where re-challenge is definitely better than topotecan per se.
12 months to re-challenge.
You'll also re-challenge. So I think unless the patient relapses within or doesn't respond to CTRT or relapses within maybe 2 or 3 months, we would prefer abstaining. Otherwise, most of us tend to re-challenge with the same. It's not moving actually, the slide set. Okay, sorry. So immunotherapies, Vivek sir, quick, your preferences. We have lots of data, nothing too impressive in terms of PFS. OS rates are somewhat better. We have now recent approvals with serplulimab. So Caspian, Empower, serplulimab, which one do you prefer?
So this is where the molecular differentiation comes into play. If we can pick and choose, I mean, that is something which is not done very routinely, but I'm hopeful that if we can target the specific molecular subtype to offer immunotherapy, that makes sense.
I'm sorry, sir, I couldn't.
The specific molecular subtype to target with
Yes,
immunotherapy.
so we'll discuss that in. Samir sir, do you want to take this question as well?
This is for extensive stage, I think.
Extensive stage, sir. So
right
you
now
have
we don't
completed your chemotherapy. What maintenance would you prefer for immuno?
So we don't have a now head-to-head comparison between all these three. But indirect comparison wise, data for serplulimab look better.
Looks
and
better.
it had, I think, more Asian patients.
Correct.
So that is close to us, but I think more or less similar. You can offer whatever you want to give.
Also, there's some difference in mechanism of action with respect to serplulimab.
So right now you would prefer serplulimab over the long-standing durva?
I'd be.
That would be ideal. So we know this was a nice Bayesian network meta-analysis which showed that some immuno is better than no immuno. So definitely for most subtypes of SCLC, that we'll discuss it. So we'll discuss that in a little bit of detail. We'll just skip this part because of paucity of time. We'll just touch on the molecular classification of SCLC because this is an exciting new era. Because it largely subtypes it into 5 types, where the last of which is inflamed subtype, which has an absence of ACLC1 as well as NeuroD1, which respond very well to immunotherapy, as opposed to SCLC-A type, which is not so great. And we have, newer trials which is coming up looking at maintenance olaparib, maintenance ibrutinib even. So I just want to ask, Samir sir, do you do molecular classification of SCLC? Because it's been validated with IHC also. So in your center, or do you send it out routinely for patients right now?
Right now, we are not doing as such classification because it's just coming up. But I think we should start doing it in future. And even now there is a data for loberonate as a maintenance.
Yeah.
Just came, I think, 15 days back.
Yeah.
It has shown impressive results, very good results.
Very good results.
So I think that would change the treatment paradigm slowly over the years, and it will definitely shift towards doing biomarkers and then deciding what should be done next.
Yeah.
So that day will come definitely, but right now it is just early days for us.
Dr. Vivek sir, are you doing it routinely right now?
No, not at all.
We were, in fact, we were thinking of doing it, but I think the IHC validation is quite complex. It's getting the reagents is also quite tough, apparently, is what our pathologist has said. So moving on to the rare tumor, 63-year-old COPD patient presented with, we did a CT, followed up with a PET CT. It's an FDG PET, it's not a dotonate PET, but we'll go to this. So I think the surgeons can start with this. Dr. Arindam, would you like to biopsy any lung nodule that you see? A quick yes or no's.
Not any, but yeah, looking at this, suspicious ones, yes, definitely.
Yeah. So in your experience, would you send this to a pulmonologist or would you send this to the intervention radiologist?
This is a central one, a pulmonologist for a radial EBUS biopsy will be better.
Yeah.
If it's peripherally situated, then more so towards the CT guided.
Yeah. Dr. Sridharan, quickly, what are your differential diagnoses in this? You see a peripheral solitary lung nodule, what are your quick differentials?
So the first things first, the commonest thing that we come across are the non-small cell lung cancers. Then comes the rare tumor, the
So given that it's not FDG avid,
yes.
What are your differentials?
So even now, I mean, like even if you look at that non-small cell lung cancers, even they can be not FDG avid sometimes. So when they are not FDG avid, we would like to have a look at the other. I mean, look at the biopsy and think of other pathologies also. Like carcinoid is one possibility, typical or atypical carcinoid, and rest of the radiologically it doesn't look like a hamartoma though. So like small cell lung cancer again and large cell neuroendocrine carcinoma.
Yeah.
These are all like further down the diagnostic.
Yeah, further down because they're definitely very avid on the PET as well. Okay, Dr. Sriniket. Yeah, so how would you do how would you work up for this patient? So it's a lung nodule, single lung nodule, FDG non-avid. We've done a biopsy. I'm telling you it's a carcinoid, a typical carcinoid, Ki67 of 1%. Please proceed.
It's 1%. I want to go for a dotate, FDG dotate.
Okay. So even if your CT scan shows that it's a single nodule localized, would you still want to do a dotonate?
Yes.
Okay. Anyone begging to differ? Anyone wants to differ? Radiologist, sir? Dr. Gaurav, do you feel it's required to follow up dotonate in all patients?
Basically, ma'am, it depends on the histology as well as thing, but after biopsy only we will decide whether we should to do follow-up or not.
Yes, sir. I've given you the biopsy. It's a carcinoid. It's a very typical carcinoid. Yeah. You have a CT scan which shows a single lung nodule. You have a FDG PET, which obviously does not show it's a non-avid lesion. Do you want to follow up all with a dotonate to look for metastasis?
Dotonate. Usually we do follow up initially for 1 to 2 years, then we can leave follow up because it's basically very benign histology and uptake is not there, so we don't follow. But initially for 1 to 2 years we should follow.
Sure.
So even with typical carcinoids, you have around 10 to 15% chance of lung, medicinal nodal.
Which may not be picked up. I think they would be picked up on the CT as well.
One small point is that if we come at it with just a chest CT scan and let's say we have a typical carcinoid, we are not 100% sure that that is the primary. It could just be the metastatic nodule which has risen from some other reason. So the thing we have right now is a 1% the typical carcinoid histopathology report. Might as well do the dotate scan.
Correct, fair enough. So you'll be sure of what you're dealing with once you do.
Also, small biopsy doesn't always give us exactly whether it's a typical or an intermediate grade. So
yeah, but that your FDG PET will anyway tell you. That for that your dotonate may not help so much.
Both doing a dual imaging is better again.
So any lung nodule, do the 3 thoracic surgeons always offer surgeries?
Invariably.
I'm sorry?
Invariably, I would. If a patient is fit and if it is not again, it's a matter of fitness. It's usually most of the NET patients, particularly the typical carcinoids, tend to happen in younger, fitter patients. Caveat is once in a while they are central, they may be very close to the carina. In those, it may usually lead to some sort of supramajor bronchial resections, carinal resections. There it becomes more a case of whether I can do it, do I have all the resources to give the optimum outcome, then I may send it to a higher center or call in help. But if fit for surgery, single site, then definitely surgery is the way to go.
Okay. Dr. Arindam, you want to...
Also what Sriniket said about these people being young, more on the younger side. So they have a long life ahead of them. So many a times we find these patients who have been debulked already somewhere else by the central tumors, basically, either bronchial or a tracheal, and then coming to us. So yes, I would offer them surgery if the PFT is good and the patient is fit for surgery.
Okay. And do all of you approach, what type of surgery do you do? Do you do a minimally invasive surgery or
Depends.
do you do a
Depends on where the location of the tumor is and how fit the patient is. If it is a central tumor, if it's a tracheal resection or a bronchial sleeve resection, sleeve still we offer VATS, but tracheal more often than not we do it open.
So in any patients, Dr. Sridharan, would you like to spare the nodes or do you definitely address the nodes for all patients?
Address nodes. So depends upon whether it is a typical carcinoid or atypical carcinoid. Atypical carcinoid, almost always you have to do a mediastinal clearance. Typical carcinoid, you can get away with the mediastinal sampling, but there is no scenario in which you can avoid it because you don't want to miss the 10 to 15%.
You don't want to miss it.
So just one couple of lines more for the surgeons in the audience. When it comes to carcinoid, there are only minimal invasive is always the way to go as many times as it is possible. Only thing with neuroendocrine tumors that happens is many a times these tend to be central. So they may be located in one lobe, but they would still be in the main bronchus of the lobe. So that leads to a situation of presentation with recurrent infections in that lobe due to the lack of evacuation of the mucosa, which makes the surgery technically feasible. So they may have to be converted to open depending on the surgeon's patience, the availability of assistance and the expertise and things like that. So that seems to happen a little bit more compared to say an NSCLC because these tumors tend to be in the body for a longer time compared to NSCLCs.
Dr. Vivek, your opinion in the era of LAR, PRRT availability, do you prefer 4 cycles of PRRT in as per the NETTER-2 trial, an indefinite LAR versus a complicated surgery for a large or a metastatic tumor?
So I personally do not have an experience with PRRT. LAR is something which has been time tested and that is what I prefer to follow.
Dr. Samir, would you like to take this question as well? So you have a patient, not obviously this case that I showed, but you have a patient with a large bulky tumor, difficult to resect, maybe, but oligometastatic resectable NET technically. Do you offer resection or do you offer PRRT LAR versus LAR alone?
Basically, these cases should be discussed in MDT and then decision should be taken after considering all the things. So if the patient is not resectable, then there is no choice. Situation may be there like we had a pancreatic tumor. It was neuroendocrine, but it was like BRPC, not clearly resectable. So we had a discussion of offering as per the NETTER-2 of PRRT plus leuprolide. We have started that patient. Just 3 months of treatment is completed. But issue is that you will get downstaging in very few patients. Most of the cases you get stable disease rather than downstaging.
Yeah, that's a big issue. Yes. So this was actually a study that was shown from TMH where they this is of course pancreatic NETs, but very interesting data where they looked at unresectable pancreatic NETs, gave PRRT and found a 23% conversion rates. So that is something which may be extrapolated to some difficult to resect.
So that is only 26%.
Yeah, but that's pancreatic. Lung might be maybe, especially for a peripheral lesion, might be slightly easier, I feel. Okay, so we won't discuss NETTER-2 for the lack of time. So thank you so much to the panelists and the organizers. Thank you.
Hello. Thank you so much, Dr. Swartika, for the very interactive panel discussion. Also thank you to all our esteemed panelists. To conclude this lung cancer session, we now have a panel discussion on neoadjuvant TKI in lung cancers. Moderating the session is Dr. Shikhar Kumar, Medical Oncologist, Yashoda Hospital, Hyderabad. Requesting our esteemed panelist to kindly join the panel, Dr. Samir Srirangwar, Medical Oncologist, NCI, Nagpur. Dr. Vinod Thakur, Consultant Surgical Oncologist, Bhandari Hospital, Indore. Dr. Rahul Agarwal, Consultant Surgical Oncologist, Apollo Sage Hospitals, Bhopal. Dr. Sanket Bankar, Associate Consultant Oncosurgery, Pune. Dr. Pushkal Dwivedi, Consultant Medical and Hemato-Oncologist, Arogya Hospital, Bilaspur. Dr. Upasna Sinha, Radiation Oncologist, Chhattisgarh Institute of Medical Sciences, Bilaspur. Dr. Alok Kumar Devangan, Radiation Oncologist, Mahasamund, Chhattisgarh. And Dr. Sushil Yeshla, American Oncology Institute, Raipur.
A very good morning to everyone, and first of all I want to say thank you to Yashwant sir and Dr. Bhavna ma'am for arranging such a wonderful conference. And as we are nearing the end of the lung track session, I think Yashwant sir has given me a very difficult task, because he has chosen a topic which is not yet the current standard of care. I think most of our panelists will agree that this is still a very new area. It's a very evolving field. And the very fact that we are even discussing TKI in the neoadjuvant space is a testament to the efficacy of these medicines, because the way they have come down from the metastatic stage to the adjuvant space and now in the neoadjuvant space is something quite remarkable. And this is not something that we do very routinely. So we'll just have a chat with all the distinguished panelists here and see what it is that they do in their day in and day out practice, and how they would approach this data in the context of what is already the established standard of care. So with that, all panelists can, I think, pitch in one by one and give me a quick estimate as to what exactly do you see in your day in and day out practice, what percentage of your lung malignancies present to you in a resectable stage. I think everyone can just give me a rough idea so that we can get an idea of how common actually this kind of scenario is. Everyone can just tell.
Actually, it depends where you are practicing.
That's okay, sir.
So
we'll get an idea by when everyone.
Less than 5% for me. Less than 5%.
Less than 5%. Anyone is seeing more
less
than
5%.
Anyone is seeing more than 10%?
No.
Less than 5%, sir.
Everyone is seeing probably less than 5% only is what I would suspect. Even in those who are practicing in tier 1 metro cities, also in corporate hospitals, also probably even there also the rates will be not more than 10% at least. So that is what I wanted to bring across, that this is a very uncommon situation. So whenever we deal with such uncommon malignancies, then again one really needs to pause and reflect, because data is on one hand and what we see in the real life is actually quite different. So say you come across a resectable malignancy, comes across very rarely, once in a while, but it does come across and it lands up with the medical oncologist's lap. So I think we have 3 medical oncologists in our panel, Samir sir and Pushkal sir. So I think, sir, you can take it one by one. From the medical point of view, how would you work up this case? What further investigations will you do before you decide the subsequent treatment? So out of these 3 options, probably what would you choose?
From therapeutic point of view, the only useful thing right now is EGFR, ALK and PD-L1. So because ALK is, we have data for alectinib also, we have data for EGFR target therapy also, and PD-L1 because we decide immunotherapy based on that. So these are the only markers which we need for treatment decision. But as the NGS is available right now so easily, so cheaply, so we always tend to use complete panel. But yes, I think many of the times it doesn't change our management. So basic minimum need is EGFR, ALK and PD-L1.
But what do you do? What do you do, sir?
I offer NGS.
You will do the limited panel, isn't it?
Yeah.
Because of how commonly it is available.
Because it sometimes helps us in counseling. So see, this is the mutation right now you have, but we will not use it right now.
Yes.
But sometimes later on, if you relapse, then we can use it.
Anyone is still doing EGFR PCR or has it become obsolete? Anyone from our medical panel? I think Pushkal sir and anyone else is there from medical side?
As we have customized NGS now, so I am fine with the NGS.
I don't think anyone is doing PCR as of now. Everyone has moved to NGS panels, limited NGS panels.
Limited lung panel with PD-L1.
With PD-L1. And with the PD-L1 platform, again this is often discussed, but are you comfortable with Ventana or are you advising DACO to everybody?
It depends upon the trial inclusion criteria, because few of the trials have used DACO platform, few trials have used Ventana.
No, but this is you have not even decided what immune checkpoint inhibitor to offer the patient. The patient has just come to you with this potentially resectable malignancy. So as a baseline, you would offer, say, either this or this. What would you invariably choose?
I would leave that to the...
No, the patient is asking you.
Both I sometimes do both, like sometimes Ventana, sometimes DACO. I don't focus much on that, because thing is that different trials have included different platforms. So if I have the immunotherapy option in prior hand, like if at all I decide on some kind of immunotherapy I want to offer, so I would just go to the trial, look at the platform which they have used, and I insist the molecular pathologist to do in that particular platform.
Okay.
That is usually what I do.
Samir sir or Pushkal sir, do you have any favorite platform, or do you say, okay, you do whatever you want, whatever comes in the coupon?
Usually, yeah.
So basically, it's always better to do companion diagnostic PD-L1 assay. But I think most of the center and most of the places, they are doing whatever available with them, and they are following that report. So even if you want to use Pembro, but you have to use Ventana, and that is showing CPS more than 110, whatever 50. So we extrapolate that and we take it as a positive or negative result. So even in TMH, I think they are not doing companion diagnostics. So they are using whatever the platform available with them.
Okay. Okay. Is anyone advising comprehensive NGS for this kind of a early resectable? Anyone would say there is some utility in doing a comprehensive NGS, or you think there is absolutely no use in doing comprehensive NGS with MSI, TMB and things like that? Or is it just for theoretical discussion, never practically done?
Yeah, it's not of any therapeutic use at that moment. Again, it can be helpful you to decide once the patient recur. Even CTDN, if you are doing it, that can help us to follow the patient after the treatment is completed. But again, that will only tell us the patient is going to recur after a few months period time, but that won't change the management immediately. So prognostication can help.
Okay, so moving ahead, so this is a hypothetical case scenario. Of course, like I said, very rare, so I don't have actual cases to show you. So this is a case which comes as across a resectable malignancy, stage 3A, because there is a single station N2 node which is proven on EBUS. Okay, the single station, say, assume it to be a paratracheal node, because that is the most common N2 node that I see, at least in my cases. Paratracheal node is N2 node, it's biopsy proven, and you do a quick NGS, and NGS also is exon 21 L858R mutant. PD-L1 is only 5%. And the surgical colleague sees the case. He is a very good, very amicable surgical colleague, and he refers the case back to medical team. Please go get neoadjuvant treatment and then come back to me. So then the ball is again in the medical oncologist's court. What would you do? You would say, no, first get operated and then come to me, or would you offer some neoadjuvant treatment? Anyone from the
so it's always
medical team
better
can take
to
this.
start with the neoadjuvant option.
So now if you had done it and your patient has been referred to you, so definitely using osimertinib as per the Neoadjuvant can be an option, because osimertinib is such an effective drug and it really gives us fast responses, and definitely patient is going to get good responses. So I think if the surgeon is not comfortable operating first, I would definitely offer the patient osimertinib.
You would offer neoadjuvant treatment. You would not send the patient back to surgery. No, there is no role of neoadjuvant.
He has already sent back to me, so I think I would give and then monitor the closely the patient. If the patient is responding, give it for 2-3 months and then go for the surgery.
Yes. From the surgical side, So would you offer upfront surgery for this patient, or would you say no, come back after some neoadjuvant treatment and then we'll operate? Would you have any issue if your medical colleague says no, let me offer some neoadjuvant treatment and then I will operate 3 months down the line? Or you say no, upfront surgery is the way to go?
Actually, the stage is 3A and node is positive, so obviously we will go for neoadjuvant in this case.
Okay, but it is a single stage, potentially resectable, single and 2 stage.
Even though the disease is resectable, but the biology is bad and stage is higher, so we have to assess the response also. If the response is good and responding disease is this, then we can have a curative intent in that. And the surgery is basically major surgery, so we should take NSCLC and followed by surgery.
The chances of taking adjuvant might not be that good, so if they can take neoadjuvant.
So I wish we had such great surgical colleagues everywhere who are so happy with sending cases for neoadjuvant treatment. But yes, I think if everyone agrees, I think giving neoadjuvant treatment is not a bad option. As far as biology is concerned,
bioselection, you will be operating a responding patient, where the chance of long-term outcome would be better.
I would just have to differ a little bit on as far as the biology is concerned, sir, because as far as overall lung malignancy is concerned, driver mutation positive cases actually are considered to have amongst the best biology compared to patients who don't have driver mutation. So with this, now panel says yes, let's do neoadjuvant treatment. What would you choose? We have 3 options, option 1, 2, 3.
So as EGFR positive, I will go for option 3 only.
Osimertinib monotherapy. Anyone would offer osimertinib plus chemo? Or you are happy with only OC monotherapy?
We'll look for his symptom, performance status, and of course we should discuss with the pro and cons of osimertinib alone, along with it should be the combined decision, combined informed decision. The patient should also know, and based on that the common decision should be made between the option 2 and 3. Of course option 1 is not a choice, I think. Option 2 and 3 we should combine decision between the patient and the physician.
Okay, so it's basically a joint decision making between the patient and the physician. There's nothing hard and fast that it's, this
for
is...
For deciding between 2 and 3, we need to have long-term follow-up and data so suggest the combination does better in long-term as compared to the monotherapy. So I think we have to wait for more data to mature and then we can decide.
Yes, so I think as Pushkal sir rightly mentioned, option 1 is definitely not a great option because the outcomes with only platinum doublet, as we all know, is very, very suboptimal. The pathological responses, path CR is in single digits, even major path response, that is 90% tumor regression on the histopathology specimen, is also very, very low. So this is of course the only trial really that we are going to discuss today, because this is the only phase 3 trial which has been done in this space, the Neoadjuvant. So these took patients, as we all just saw the case we discussed earlier, resectable malignancies with EGFR sensitizing mutations. And 3 arms were there. Placebo arm was only chemo, and the 2 experimental arms were OC mono or OC plus chemo. Then they all went, they took the treatment for an average duration of more than 9 to 10 weeks, and then they underwent surgery. The interesting thing is that again all arms were offered adjuvant osimertinib. So basically this is a perioperative treatment. This is not only neoadjuvant treatment what we need to know. And most interestingly, the primary endpoint was major pathological response, not even path CR, it was only MPR, and this was justified in the paper saying that to recruit the trial quickly and to finish it, this endpoint was chosen. So what is interesting to note is that more than 90% patients, they underwent surgery. So if the concern is that patients will drop out, they will progress and they will not come up for curative surgery, I think this at least that can allay the fears of the surgical colleagues that patients will not drop out, because the rates of surgical conversion are very, very high. Only in the placebo arm, as you can see, 11% patients, they did not undergo surgery, half of them due to disease progression. But in both the OC arms, the surgery rates were in excess of 90%, and the vast majority of them were again R0 resections. So overall, if you see the safety wise, in terms of loss of surgery, that risk is at least very, very low. So this is what I wanted to discuss. So you can see there is hardly any difference in the MPR between OC mono versus OC plus chemo. So anyone would still say OC plus chemo has any additional benefit in this, or OC mono alone is doing the trick?
That is what I said. We said we need long-term EFS data. If that shows chemo plus OC is better,
Yes.
then only it would become an option, because in short term, the OC monotherapy arms looks
Yes.
as okay as combination. Even the fitness for surgery would be better if you give only OC.
Yes.
So toxicity would be less.
Yes, we don't have the long-term data yet. No, we just have the short-term data. Another interesting thing, this is something of interest to our surgical colleagues especially. See, nodal downstaging is something which is a new concept, at least for me. So what I understood from this paper is that nodal downstaging in patients who had N2 disease. So clinically N2 at baseline. So biopsy proven multistation N2 disease. At the time of surgery, downstage to either YPN0 or YPN1. This happened in almost half the patients who were on OC or OC plus chemo. So with this data, now that you are seeing such responses with OC mono or OC plus chemo, your N2 disease is getting downstage to YPN0 or YPN1. Would you be tempted to offer this regimen in patients who have multistation N2 nodes as well as a neoadjuvant? And then would you want to operate these patients later on? When you have such compelling data of almost 50% patients getting downstaged. Again, this is all subgroup analysis. This is not powered. There were small patient numbers. Only around 30% patients had N2 disease in this trial. But still, you are seeing close to 50% patients who are getting downstaged to a different YP end stage altogether. Something to think about, because patients who were previously deemed unresectable because of multistation N2 might be converted to potentially resectable disease because of this treatment.
So
long-term data, as we yes.
Yeah, so definitely downstaging is good, and the surgical fallout means like only 5% patients are not getting operated.
Yes.
So maximum patients are getting operated. So there is no, I think, negative point here not to offer neoadjuvant osimertinib. So it will make the surgery easy. It will improve the fitness of the patient. It will give you time to improve the general condition of the patient, make the patient fit for the surgery. So everything looks okay, I think. And again, we are going to give the adjuvant osimertinib also.
Yes, that is most important, because all these patients, they go on to receive adjuvant osimertinib. This is not only a neoadjuvant trial, this is essentially a perioperative trial. As Samir sir mentioned.
Toxicity is also very less.
Sorry?
Toxicity is also very less.
Yes, I'll come to that. So long-term data is still pending. We just have the 12-month EFS data. As you can see, at 12 months, there is some difference around between the OC arm and the placebo arm, but it's still very immature. And as Samir sir told about the toxicity, so as you can see, the median exposure to osimertinib was around 75 days. Grade 3 toxicities were there, especially more in the OC plus chemo arm, but very serious toxicities leading to treatment discontinuation were thankfully very, very low. And there were no major wound complications or any other post-surgical issues noted in patients who were in the experimental arms. Coming to the trial design, MPR. So this is again a very theoretical discussion. MPR as a surrogate endpoint. So do you think that this is something which is of any value, major pathological response, or do you think that all these trials should have a more hard endpoint like a overall survival? Is it even practical?
In the neoadjuvant IO trials, most of the immunotherapy trials have put the endpoint as EFS. So I expect EFS may be better endpoint in neoadjuvant trials rather than measure pathological response.
Some trials have included MPR as a primary endpoint, especially these Chinese immune checkpoint inhibitors, NeoTorch, even the rational trial with tislelizumab, they included MPR as one of the co-primary endpoints. Okay. So MPR, although it is not a validated surrogate, but it is highly prognostic. So if you see, this was another paper which looked at the outcomes of patients who had increasing amounts of residual disease post neoadjuvant treatment, and the hazard ratio for death goes up quite drastically. So patients who have less than 10% viable tumor, you can see that the outcomes are actually much better than the groups of patients who have more and more amount of residual disease left. And like I said, the rates of successful surgery were quite high, higher than in fact the driver negative immune checkpoint trials, where it was around 80% or so across the trials.
Actually, the MPR gives them a chance for getting early approvals.
Exactly.
So that is the advantage, but I think we should also try to get the follow-up data and the what is the EFS and OS coming up.
Yes,
But
yes.
that will take definitely long time in such cases.
Yes. So I think we have ignored our radiation colleagues. So coming on to the last case. So now you have a multi-station N2 nodal disease, paratracheal, subcarinal, AP window, and these are all now biopsy proven on EBUS. And this is again now on NGS EGFR exon 19 deletion positive. So this is T3N2 3B. So coming to our radiation colleagues, how would you approach this case? What are the quick criteria you use to determine that yes, this is a good case for definitive CTRT, or you would say no, I will not do definitive CTRT in this case?
Actually, we'll go for adjuvant CCRT. It's better. We'll go for first that, and then followed by in a maintenance we can give like osimertinib.
Okay, so you will give definitive CTRT. Any case with 3B, you would say no, this is not a good candidate for definitive CTRT.
No, it is a good candidate for CCRT. We can go definitely with that 60 to 66 gray. If it is unresectable, obviously it is unresectable disease. So we'll go to 60 to 66 gray in that.
Dr. Alok is also there? Yes, sir. Any case you would say no, this is not an ideal candidate for CTRT. You can go ahead with neoadjuvant followed by surgery only. I will not do CTRT.
No, sir, this is the case scenario. This is definitely go give for the definitive CTRT. And definitely go for the accurate dose 60 to 66 gray, and after this performance this response definitely is a good case.
Okay, so radiation oncology colleagues are very clear, they will do CTRT in all cases, and followed by medical oncology colleagues will put them on adjuvant osimertinib because of the strength of the data of LAURA trial. So you can see that the PFS was actually quite underwhelming on the placebo arm, just 5.6 months. And unprecedented PFS in the osimertinib arm with a median of 39.1 months. And stage 3 and stage 3B, 3C did as well and even better than stage 3A in this group. This is the last point of discussion because ALK positive neoadjuvant is virtually very unheard of. Multi-station N2 nodal disease, would our surgical colleagues be tempted to do surgery if the patient responds very well to neoadjuvant TKI? And there is some data as well. I pulled up this paper. It's not with osimertinib, I know. I could not find any paper with osimertinib, but aumolertinib is also a third generation TKI. Look at the response rates. With exon 19 deletion, 91% response rate. 23 patients converted to R0 resection with a decent 2-year EFS. Patient comes to you with 3B disease after 3 months of osimertinib. The nodes have regressed in the PET CT, primary has responded by 70-80%. Would you attempt to do a surgery, or would you say no, multi-station N2, go for CTRT, no role of surgery? Has anyone had any experience in this matter in our surgical panel?
Not exactly, because outside institutes or outside the trial setting, I don't think so. You would be attending surgeries in these cases.
No surgery? All cases for CTRT?
Yeah.
Okay, I think that is the end of my panel because ALK positive adenosine lung is rarer than seeing a unicorn. Anyhow, this was a phase 2 trial done in this setting. Alectinib was given in the neoadjuvant space. Again, primary endpoint was a major path response. Very small phase 2 trial, even in a 7 to 8 years, they could only recruit around 33 patients. But again, they are seeing a decent major path response rates of around 42%. And you can see that majority of these were partial responders, and this is again some nodal downstaging also was noted in this trial. So that is the end of my panel. Thank you so much, and I hope that this was of some use.
Thank you, Dr. Kumar, and all our distinguished panelists for an engaging discussion on the role of neoadjuvant TKIs. With this, we conclude the lung cancer track. Thank you to all our speakers and panelists for their time and valuable insights. We will now take a 10 minutes break for tea and coffee and reconvene for the communication skills workshop. Thank you.
इलाकांमध्ये खालतं थर जो वरतं नाही सालवरून द्या ना.
टेबल लाने दे, 1 मिनट तू.
Yeah, so that's my first lot, and then the second lot, and then the third. Yeah, that's great. Yeah. But when the other ones come up in the middle, then they come back to this one again? Yeah. Perfect. That's excellent. What do you think? Avinash is the boss.
We will be starting with the communication skills workshop in the next 5 minutes. I request everyone to please assemble and be seated.
You're wonderful.
Hello, check. Hello, hello, check. Hello. दो मांगे आओ
Excellent. Yeah.
This is the 10 seconds PD. This is the 10 second PD check.
Check.
Depends on how long you've had this off the mark. How long you know them.
So chest is
Oh, nice. Yeah, nice.
वायर एकदम फिक्स हो गया जो डॉक्टर में ब्लैक वाली उसके सामने इसका थोड़ा आवाज़ बढ़ा के सामने रख देना कैच कर लेगा आवाज़ देख है ना कौन किसने
He must be the doctor. Yeah.
So they cannot push it because the wire is very short. So the two person there is
if they have the
and one mic is there, and her statements are on 2 sentences.
Good.
So she can
Okay, she'll be okay.
Yeah.
Perfect. Excellent.
Hello. Audio. Okay. Like this. So, good afternoon, everyone. Welcome to the Track 12 Communication Skills Workshop. As oncologists, we often face the responsibility of guiding our patients and their families through some of the most difficult conversations, whether it is discussing prognosis, supporting decision making, or providing comfort during end-of-life care. Today's workshop is specially designed to help us refine those crucial skills, balancing honesty with empathy and clarity with compassion. We are honored to have with us our esteemed panel of chairpersons, Professor Christopher Jackson, a leading medical oncologist from New Zealand, specializing in GI cancers and melanoma, Dr. Riyaz Shah sir, a thoracic oncology expert from NHS UK. We warmly welcome all our audience as well. To begin the workshop, I invite Professor Martin Stockler, eminent oncologist and clinical epidemiologist from NHMRC Clinical Trial Center, to deliver the welcome and introduction.
Thank you very much, Dr. Harshitha. Can I just check, can people at the back of the room hear me? Can you put your hand up if you can hear me, please? Fabulous. Excellent. So it's a great privilege and honour to be working together with you today for this communication skills workshop. Just in case we run out of time, because we never know how long we've got, the 5 key messages for today are that patients and families want more information about prognosis than they've got. Information about prognosis is critical for planning and for decision making. Information about prognosis improves the quality of life of patients and carers. Information preferences vary between individuals and within the same individual over time. And there are prompts for questions about prognosis at 7 key time points. And I don't want to give you any anxiety, but unless you can get all 7 time points, you are not allowed to leave the session at the end of the room. There will be a test. So, just to make sure that everybody is awake, listening and ready, I want you to put your hand up if you've been asked in the past week or two this question. How long have I got? Who has been asked that question in the last week or two? Okay. How about, should I keep working? Who's been asked that question? How long have they got by the relatives of a patient? Yep. Will I be able to travel next year? Who's been asked that question? Is treatment for my cancer a good idea? Is this patient suitable for ICU admission? Who's been asked that question in the last week? Is this person suitable for hospice admission? Great, okay. Now we will provide some anti-inflammatory drugs for your sore shoulders. So, what we're going to do today is talk about what to say, when to say it, why it's important, and how to speak about these things. We'll have some excellent presentations on empathic communication and avoiding burnout. We're going to think about how to think and talk about survival time, and we're going to have some exercises on recognising and responding to emotion. And this 2 hours is going to be divided roughly equally into us giving you information and you practicing and doing drills. So, it's a fantastic dream team of people that we'll be working with today, and we'll work through those as the session starts. So the next activity is going to be a role play, and so we have our doctor, patient and daughter sitting on the stage ready to go. So, what is the problem? The problem is that people with advanced cancer and their families want more information about their prognosis. Prognostic information helps people plan for the future and make informed decisions about treatment. Communicating about prognosis is a fundamental skill for oncologists. Prognostication is daunting. What does all this mean? So, prognostication is an expert's formulation and explanation of a forecast of future outcomes. That's the definition. So an expert is you. You're knowledgeable and you're skillful. When I say formulate, what I mean is a concise and systematic expression. The explanation is a statement that makes clear. The forecast is your prediction or estimation, and the future outcomes are how things are going to turn out. That's the task that we're trying to work on today. The reason I say it's fundamental skill for oncologists is because it's the necessary basis, core of central importance. There is no decision you can make, no recommendation you can give without considering the prognosis of the person you're speaking to. Actually, for them, there is no way they can make an informed decision or a choice or a plan without having that information. That's why we say it's fundamental. Without this, nothing can proceed rationally. Synonyms for prognosis are the words expected or estimated survival time, life expectancy. It is fundamentally quantitative, and by that it means we have to have numbers and we have to have units. Unless you're talking about those things, you're not really talking about prognosis. And it's probabilistic, and what that means is that it is inherently uncertain. We never know how long somebody is going to live for, what their chances are, so there is uncertainty associated with it, and that means we have to talk about probabilities and chances, not about certainties. What does daunting mean? Daunting means seemingly difficult, intimidating. That's what it is for the doctor, that's what it is for the patient, that's what it is for the family. So, let's try and take nothing on its looks or its appearances. Let's look to the evidence and apply that. So, this is a study that was done at Tata Memorial Hospital about 10 years ago by C.S. Pramesh and Sabita Jinawal, Reshma Ambulkar and Vandana Agarwal. The preconception, what's the preconception? An idea or opinion formed before having the evidence for its truth or usefulness. The preconception was physicians, this is what they wrote in their paper, think that Indian patients and families blindly trust doctors and don't want information about their illness and treatment. So what they did was that they designed a study to work out how much information do cancer patients want from their treating doctors. They surveyed 140 consecutive thoracic cancer patients and their relatives, and they found that half of them wanted more information about the patient's illness. That's both the patients and their relatives. About 3/4 of them thought that the patients should be given details, even if upsetting. That's 3/4 of the relatives said their patient should be given more information, even if it's upsetting for the patient. And about 90% said that relatives should be more involved than patients in decision making. That probably would be different in Australia, very important for us to appreciate. The implications are that patients' and relatives' information needs should be acknowledged and addressed. So, we've talked about why conversations about prognosis are so important, but let's flesh that out a bit more. So patients who are aware of their life expectancy and had end-of-life discussions with their doctors, this is in studies done mostly in the United States, were less likely to undergo aggressive end-of-life care, intubation, attempted CPR, less likely to die in hospital, had earlier engagement with palliative care, had better quality of life at the end of their lives, measured, and had better quality of life for their carers after they died. And a precise understanding was not necessary, as long as the patients knew that there was at least a 10% chance of dying within the next 6 months. That was enough to make a difference to their treatment preferences. So, when should you be thinking about this? Ask yourself the surprise question. Would I be surprised if this patient died in the next year? If the answer is no, I wouldn't be surprised. That means prognosis warrants discussion. It means the chance of dying for that patient in the next year is 7 times higher than if you would be surprised. And so this is a simple screening test for doctors. Before the patient comes in, before you even pick up the notes, think, would I be surprised if this person died in the next year? And if the answer is no, I wouldn't be surprised, you should be thinking about encouraging a discussion about prognosis. So we surveyed over 200 medical oncologists from Australia and New Zealand. This is Anuradha Vasista, who did a PhD with Belinda Carley and myself. And we asked them about these triggers, and 98% of doctors in ANZ, oncologists, said that if a patient asks, they tell. 90% said that when no further systemic therapy is planned, they would talk about prognosis. If the estimated expected survival time was less than 6 months, about 3/4, following disease progression on an anti-cancer therapy, about 60%, so that's the scan talk. You have the scan shows the cancer is worse. You should be thinking about talking about prognosis. At the initial consultation, about half the oncologists thought prognosis should be discussed, and nearly half when the patient was hospitalised. So, the 5 takeaway points. Patients and families want more information about prognosis. It's critical for planning and decision making. Information about prognosis improves quality of life of patients and carers. It varies within individuals and over time. And there are 7 key time points when you should be thinking about prompting the question to ask you for prognostic information. I'll now hand over to Avinash Tiwari for the role play exercise. Thank you very much.
So good afternoon, everyone. We know this is more dreadful time because we are between you and the lunch. But believe me, this is going to be very much interesting. Thank you, Dr. Martin, for all the leadership and guidance. So before role play, I will just ask everyone to have a club of group. So because we are going to have certain simulation and discussion between, it is going to be more of discussion. It's not going to be one way, it is going to be bilateral discussion. So if you can club ourselves in the group, please. And I will insist there should be one oncologist in the group. I request to please be arranged in the group. That will be an exercise, so you will love it. Ma'am, please, if you can do in the, yes. Yeah. So, Deva sir, please, part of any group, please. Excuse me for my request, but this is how we want to do it. So in a very busy OPD, today we have a patient, and Dr. Harshita is sitting in the OPD, and there are 20 patients in the queue, and this lady with advanced malignancy comes to her chamber along with her daughter. So Dr. Harshita, as a doctor, you can just show your presence. Dr. Vinita as patient, and Mrs. Sivani as a daughter to the patient. So let me begin.
Hi, good afternoon, Mrs. Vinita.
Good afternoon, doctor.
I know that you have been through a lot of scans and treatments lately. Today, I would like to take out some time and discuss where we stand and what to expect moving forward. Is that okay with you?
Yes, doctor. We have been wondering, now what next?
Well, before I go into the specifics, can you tell me what you understand about your condition?
Well, I know the chemo hasn't been working like we hoped. I figured that means things are not looking good so for me.
Yes, you're right. The present scans show that your cancer is progressing despite being on treatment.
Doctor, are you sure that we have explored all the treatment options that we have?
I wish I had better news for you, but it looks like we have exhausted all the effective treatment options.
So this is it, doctor?
I'm sorry, but this is it.
How much time do I have with my mother?
It is very difficult for me to specify a number, but based on my experience and seeing patients with similar condition, somewhere between 3 months to 6 months is what we are expecting. It can be shorter or longer.
I see.
I know this is overwhelming for you and it is very hard for you, but if you don't mind me asking, what is your major concern right now?
I will be in pain forever now. I want to be home. I don't want to spend whatever time I have in a hospital.
We will try to make you pain-free. Even I am of the same opinion that you should be spending most of your time at home.
Will she be in pain during this treatment?
We will try our best, everything in our capacity to make her pain-free.
Life is so unpredictable, doctor. I have so many things to do. My daughter's wedding is next month. But thank you for being honest for me. I don't want false hope.
I respect that.
This is not fair, doctor. This is not fair.
Sorry, doctor, for her misbehaving.
It's all right. I refer you to the palliative room in ground floor.
So thank you so much for such engaging role play, Dr. Harshita, Dr. Vinita, Shivani. So we have got the crux, what we deal with in our day-to-day practice. Okay, being in English is not at the real life situation, but we have tried to inculcate what actually we face in real life. So I just want to take this role play as trigger. We have 8 minutes for the discussion, and let we discuss among the group what went well in this role play and what could have been done better, and collectively for last 3 to 4 minutes we will discuss how we can reflect into this role play and how we can do it better in our day-to-day practice. So taking lead from this role play, you can discuss among yourself, then we will have your inputs. You have 5 minutes for discussion. So give me one mic so that I can. So any table are ready with their points? Thank you.
Good morning to all of you. I am Colonel Chavi, nursing head in Balco Medical Center. It was a wonderful play. I think everybody has felt it, how the things goes when a patient comes with a hope and the relative accompanies them. Both three of them are wonderful. But certain thing, as if I put myself on that same place, I felt, I think the word exhausted has really put me very, very, in a way. A doctor should never say, as you say, the Indian crowd, they always take the doctor as a God, next to God. So that exhausted word could have been a better synonym. Second, the daughter, she just went off without being with mother. That should have been there. And recently, that's professor, she's come from Lebanon. She said end of life care is not end of life care. Exhausted means everything is over. So end of life care is a life beyond a life. We need to present in that way. And the last word should be delivered by the counselor, I just feel. Before delivering the last word, I think they should be counseled. The family should be taking confidence. If a person is not accompanied by the family, can be a neighbor, can be a close friend. I think that is my opinion. Maybe there is a better opinion. Thank you so much.
Thank you, ma'am. Thank you, ma'am. Any other table ready with their points? Yeah.
Thank you. We five are here, and we think that the symptom addressal should be better. We don't think that only pain is the concern. Concerns are anxiety, stress, nutrition, vomiting, etc. And it is not only at the ground floor our palliative care system is there. How the home care will be taken. What are the support system at home? That also should be discussed. And expertise, different expertise, not only the palliative care doctor, but they are physiotherapists, there are other psychologists, nutritionists. So all these things I think should be discussed.
Thank you, sir.
Avinash. So this opinion from our group, and first of all in our group we have Dr. Abha Dharewal madam. She is a patient, doctor herself, gynecologist and a cancer survivor. So a couple of points are from her, and then from 4-time cancer survivor. So big cheers for her first of all. And then in the group is Dr. Amol sir, of course, and few of my and our opinion. So first what we felt was in this discussion, the daughter was not prepared. So the reason why she was not prepared was that she was not aware of the prognosis earlier, and maybe this is the first time we are having a discussion on palliative and end of life care. So early incorporation of palliative care in this case would have made her more prepared. So that was our number one take. Second was the personal connect and touch of the doctor with the patient was lacking. So we were sitting at a distance and explaining the prognosis that in the next 3 months she's going to die. So maybe we could have just hold her hand, and maybe some physical touch would have added more difference in adding value. Third is maybe the discussion began with, I have seen your scans. It could have actually began with, how are you, where have you come from, you had your breakfast, how is the daughter studying, and then we would have actually taken the discussion to another level. And fourth was, rather than directly telling to the patient, maybe we would have engaged first with the daughter and then with the patient. So that would have helped her prepare in a better way. Anything else? So that's all from us.
Excellent points. Excellent. Thank you so much, Dr. Ravi and team. Dr. Yeshila, you want to say something? So just in constraint of time, we will just wrap it up.
I'll just tell one point. Good point is honest. The doctor was honest, but a bit more brutally honest. So what could have been better? So in the Western countries, most of the there is a relation between or bonding between the doctor and the patient. In India, the counseling happens mostly with the doctor and relatives, because most of the times Indian patients, especially females, are very sensitive to being honest, and giving timeline of 3 to 6 months on the patient's face, something which we should avoid, because that's how in India the decisions is mainly family based rather than individual based, because in Western countries the decision is by the person, not by the family, but in India the decision is from the family rather than the patient. So first I would counsel the patient attendants, sensitize them, then discuss with the patient.
So thank you so much everyone for your inputs, and
I will just add one point, that maybe during the initial periods you need to first build up the rapport, and maybe we may need more than one sessions to rehearse the full thing. So not in the single session, but maybe more than one session.
I do understand, just I am diverting. There are international faculty here. Spent couple of weeks in USA this year. There is no much of difference. हम सब एक हैं, सब जगह आदमी की इमोशंस भी वही है. जो यहाँ पे जो कैंसर पेशेंट है उसका दुख दर्द भी उतना ही है जितना अमेरिका का है. It's a family or it is the individual. यहाँ पे भी ऐसा नहीं है. So we should, I think, break this rule of Western and the Eastern. When patient comes, everything is same. That's what my understanding. If anything to differ, you can tell your differences. But जब भी ये बात आती है कि हम अलग है, हमारा अलग patient है, patient रो देगा, this is all the way of expression. But behind that expression, the emotions, the feelings, the expectations remain same. That's what I'm trying to say.
Thank you, sir. Dr. Devyamnude, sir. 1 minute, sir.
Yeah, so already I have discussed that maybe it was a very blatant on the very first day, but first of all, the discussion should have been started earlier, before in the initial part of the treatment also, and when they will be telling about the prognostic, what can happen in the next options and what are the other options available, and maybe sometimes divulging this type of news may take more than one session. So on the single sessions it may not be complete, but we will first reassure, we will build the trust, and the next sessions we will be divulging more and more like that.
Thank you so much. So actually the role play was scripted in that way, that something was actually good in the role play, and something actually triggers our discussion ke what could have been done better. So like with the first sentence, the reflection, that is, the start was good, and like Dr. Ravi said ke there was some personal input. How are you? Did you have your breakfast? Sorry to make you wait. These are actually good sentences to start the communication. And then we have the second sentence about the open-ended question. Tell me about understand about your condition so far. That is also a nice open-ended question to lead the conversation. Later, further our reflection was that about the cancer progression discussion. So the reflection was quite acceptable. And she actually tells she actually sparked the discussion about prognostic communication, and doctor actually used silence very good, and she actually took a good pause in between. So we are reaching the limits of what medicine can do. This was the statement from the doctors. It could have been done in a better way, like we still have ways to help. ways to keep you comfortable, manage your symptoms, and support you and your family through this. But in terms of treatment, aimed at curing or controlling the cancer long term, we have medical limitation. We were searching for the word for exhaustion. So this is more of explanatory sentence to cover this up. And another thing, the sentence from the doctor, it's not possible to give exact number when we actually estimate the prognosis. So Dr. Martin will throw some light on that during his upcoming presentation. But it differs in patients with educated versus limited literacy. So it is very much individualized in our region, in our country. And further about when the doctor said, we will try to manage pain, I also feel you should be at home for most of the time. She actually acknowledged the preference of the patient, but actually she would have been gone better into the home-based care, like sir said. So that makes a lot of sense that you want to be at home. We can work together to make that happen, to get you support you need at home through palliative care and possibly hospice when the time is right. So, and when she said that the doctor asked to doctor, will she be in pain? So it would have been better answered, we will do everything we can do to make sure she is comfortable. That are very good ways to manage pain and symptoms, and our palliative care team is excellent in that. So that they can have a rapport about the palliative care team, otherwise they will feel abandoned, okay? So, and the last part, please connect to our palliative care team, room number 4, ground floor. So that is now how our referral should be. A referral should be, we will be with you each step of the way. Let also connect to our palliative care team. I will make an appointment for you. Speaking to your palliative care colleague is always help over phone. And then you can discuss about the specification of the cancer and the clinical characteristic. And then you can say, I'm going to call palliative care physician after this meeting. I will be actively involving in cure. Even if you don't have any options for cancer doctor treatment, if you say this to the patient, they feel a bit of assured and they don't feel abandoned. Most of the time, the frustration and the distress is because they feel abandoned. Now there is no treatment. I am being switched over to another treatment. This should feel like that there will be an extra level of support for me, and still doctor will be my treating physician. So it helps in that way. So I will be actively involving the cure with them, helping you in plan, answering questions, and focusing on what matters most for you. Thank you so much. Over to you, Dr. Martin. And the anger, the daughter left with anger. So that also give or reflects how we should handle such kind of anger, because we encounter it in our clinical practice. Thank you so much.
Thank you, Dr. Tiwari. We will, moving forward, I invite Dr. Yogesh sir, neurologist and public health researcher, whose work focuses on in underdeserved communities, to speak on principles of empathetic communication.
Can I move the slides for? How do I move slides? So good afternoon everyone, and thanks for very actively participating. We wanted to make this session a little different, and next we'll be talking about principles and practice of empathetic communication. And again, this would be a very participatory session, because we understand that all of you are practitioners and have some or the other experience in dealing with these situations. So we'll start with a thought experiment. Next slide please. And this thought experiment is where we get into patient's head. So I ask you to close your eyes, and the doctor, you have been in, to visit a doctor, and doctor has conveyed to you that you have been diagnosed with lung cancer. Now, I don't wish any one of you to be diagnosed with a cancer, but this is just a thought experiment. So please close your eyes, and we'll go through what are the thoughts that would come to your mind. So close your eyes for 30 seconds, and then we'll start the discussion. Please close your eyes for 30 seconds. Okay, now you can open your eyes. So what are the thoughts? I would like to hear a few thoughts. Yes, sir, please.
I am a cancer survivor of liver cancer with a liver transplant. So I have kept, दो यमदूत मेरे दोनों कंधे पे बैठे हैं, so I don't fear of dying. That is my thought.
Thank you, sir, for sharing. Any other thought? Yes, sir.
So, empathetic communication, I think the first thing is that we all should be on the same page with the patient.
No, but what is the thought? So let's say, a physician has conveyed you this news. What are the thoughts that come to your mind? Because we need to understand them to have an empathetic communication. So what were the thoughts that came to your mind?
So when the physician communicated that this is the end of life,
Okay.
The first thing that would be that how is the rest of my life going to be?
Very nice. Thank you.
That is the first thing.
Thank you.
Second thing, what all things can I do and what all things I cannot do?
Absolutely.
So
Absolutely.
that is the second thought. And the third thought is that as a patient, as a lay person, will my family be affected and how we can deal with that in the best possible way with the least possible pain to me as well as to my family.
Very nice. Thank you. Thank you so much. So these are, the common thoughts that patients go through, and we need to understand them. As physician, we need to really sort of, yes, there's one more person.
Good morning. Good afternoon. The first thing which comes as human beings is why me?
Exactly. Right.
That's the only thing which comes.
Right.
Rest all things comes later on when we go deep into it, but why me is the first question.
Absolutely. Great, great. So can we move on to the next slide? I think I can move it from here. Okay, great. So some of, we already know, can the diagnosis or prognosis be wrong? Why me why now? What will happen to my family members? Am I going to die soon? Where will I get the money to treat cancer? So these are the thoughts that patients go through. And, essentially as doctors, we have sort of often have to break bad news, and we casually say bad news, but what is bad news? So there is some definition to it. So any news that drastically or negatively alters the patient's view of her or his future. So that is bad news, and we need to sort of keep this in mind. And then there are, when there are interactions with the patient, there are doctors' perspectives and there are, patients' perspectives. As doctors, you're often going to tell bad news in matter-of-factly manner, because we, with so much of technical training, we become very technical and technician-like. And you might be worried about the number of patients waiting in line outside your chamber. So from doctor's perspective, we are more worried about giving the technical information than the emotional, dealing with the emotional aspect of it. It is exactly opposite on the patient side. So what are you going to say in the next several minutes is going to profoundly alter the life or world of the patient or family. We don't understand. This is almost, when we cure patients, we almost have godly powers to do things. But when we, deliver a bad news, we are also within few minutes, we are going to shatter that patient's or family's life. And they are going to struggle to fully comprehend what you have said. They will need time to assimilate and plan. So again, from patient standpoint, their needs are more emotional than technical. So these are the two competing perspectives that we deal in this relationship between doctors and patients. Next slide, please. So what are the challenges that are faced by doctors? So not knowing all the answers. Patients expect that we should tell them everything, to plan their future. Knowing very little about patients' social and emotional background and preferences. We don't understand that human being as such. Our interactions are often 15 minutes, 20 minutes max. We fear with, we have fear of expressing our own emotions when we deal in such, when we have such interactions. We have very little time available, and at the same time, we are expected to be very kind and supportive. So it's a mammoth, it's not an easy task. So that brings us to, the empathetic communication. So what is empathy? So empathy is essentially ability to understand and share the feelings of another. And we also need compassion, and compassion is a concern for sufferings or misfortune of the others. So we have to, these two very important words, we use them casually, but there are profound meaning into this word. So how do we communicate empathetically with patients and families? And is there any systematic work done on this field? And a lot of this is, the work that is done comes from social science background. So we have to combine the social sciences and the very hard technical data that we have. So there are multiple structured approaches, and we'll just discuss one structured approach. It's called Spikes approach by Bailey and et al. And so the Spike stands for S is setting up the interview, P stands for understanding patient's perceptions, I stands for getting invitation from the patient to discuss, K stands for knowledge and information to the patient, E stands for addressing emotional aspect of it, and S stands for having a strategy or summary to go ahead. So that is Spikes, and so we'll go into little details. So in the setting, we need to make sure that when we are breaking bad news, the setting is appropriate. There is, physical space is enough, which is a challenge in busy cancer centers. Our body language should be, sitting while speaking in open posture rather than, standing and delivering the bad news while we are on rounds. Then turning mobiles off. This is a new thing that we have to deal with. Is often you have telephone rings ringing, and this whole sort of setup that you have created to deliver such a serious news gets affected. Perception is very important. We need to understand how patients and families what perception they have, because there could be denial, there could be wishful thinking. And for us, denial is a word which we put the onus on the patient, but sometimes denial could also be a coping mechanism. So we forget that denial could be a coping mechanism. Should not shatter coping mechanisms of the patient and family. So this we need to understand that. Then once we have sort of understood the perception, then we should get invitation from the patient to discuss what all aspects that he or she would like to discuss. And then we share the information, which is the very technical content that we are good with to deliver that technical content. And then you have to make sure that we need to anticipate emotional response. In the role play that we just saw, the emotional response of the daughter was anger. So there could be crying, there could be silence, there could be anger. And we need to respond with being appropriate and kind response, like I can understand emotions that you are going through. This is often saying this is very important. We often forget to say this. And then strategizing. Once the patient is ready for discussion for the treatment, then present the treatment plan considering patient's wishes. So always keep in mind that we need to keep patient's wishes at the forefront. So what are the things that I keep in mind? So one thing that I always, to keep my communication empathetic, getting into patient shoes of the patient. That's why we did the exercise that we did at the beginning. And then we are in a double role. So as we are a fellow human being, which often as doctors, this role gets sort of pushed down. And then we are also technical expert or person. And when I say technical experts, we are also problem solvers and helpers. Then, support and hope is very important, and Dr. Tiwari briefly mentioned this. There should not be abandonment. So when often the oncologist refers the patient to palliative care, meaning the oncologist has abandoned that patient, and then you fall into the realm of palliative care. So that should not be there. And even saying simple things, now I can't do anything, is an abandonment for the patient. So the patient starts feeling that now these medical people are abandoning me, and I don't know what will happen to me. Then giving time for patient to assimilate the news, listening to understand, silence, these are very important things. It's not necessary that you should always speak as a part of empathetic communication. Silence could also be a powerful tool. And then when we plan, the goals of care need to be discussed with patient before sort of going for plan of action. And we also need to understand that the goals of care can switch during treatment. So the patient might say that, I don't want, I want very aggressive care, and then when they see aggressive care, its effect on their body, they might change the goal of care. Do not forget palliative care. Palliative care should start right at the beginning of the diagnosis. So palliative care is not when it's a stage 4 and you can't do anything, because palliative care also deals with other aspects where the at medical technical person we don't have time or bandwidth to support them. So it includes patient comfort, support, religious and spiritual aids. And allow patients and family to ask questions. And if they don't ask, I actually ask if they have any question. And if they don't have any question at that time, because you have delivered a very, sort of loaded information in a very short time, they may not have time to think about it. So I always tell them that you can write it down and come with all those questions in your next visit. Don't forget relatives, because oftentimes the relatives could harbor guilt that they did not bring the patient early on. So it's always important to reinforce them, saying that you are taking good care of your loved ones. So any positive feedback would be appreciated. Offer personal example. If I would have been in your position, I would have done the same, or I could have done things differently. Whatever it's always good to put yourself in patient's shoes and tell them that how I would have done things. So. To end, what are the 6 take-home messages? So think how the patient would like to receive bad news or prognostication. Use common sense and humane approach. Keep dignity, compassion in mind. use some theoretical guidance, and essentially each of us are different practitioners, so we have to develop your own method of communicating the news, and then we constantly improvise. So with that we'll stop, and then we have this exercise for you. So in the first session you critiqued a performance, now you will have to be in that role, and so each table where there is an oncologist, I would like you as a group to develop an example of empathetic communication and practices. So we have a patient, 67-year-old smoker with newly diagnosed metastatic squamous non-small cell lung cancer and symptomatic brain mets. Family asked what is the prognosis with the treatment, chemotherapy and radiation to the brain. So we have about 8 minutes. So we'll have 5 minutes of this, where you will discuss it as a group, and then 3 minutes we'll share it. For those where there is no oncologist, you can list down what are the things that you would expect as a patient as a part of empathetic communication. So we start now.
प्रोग्नोसिस विद ट्रीटमेंट, प्रोग्नोसिस विद ट्रीटमेंट को कैसे डिस्कस करें? नहीं प्रोग्नोसिस विद ट्रीटमेंट, नॉट प्रोग्नोसिस विद ट्रीटमेंट.
Okay, so we'll start reflecting on this thing that we just discussed. So we'll start from, we'll try and go from different groups, and you have to share what you have discussed briefly in the group. And
so I was playing a patient, and Dr. Krishna, he is a medical oncologist, so he was explaining me, and I found he was very reluctant to convey everything. He was this was of course first diagnosis and first interview, so he was kind of reluctant. He was trying to pacify me. In fact, I was directly asking, is it a cancer? So he was trying to beat around the bush by saying it's a gaant hai, brain mein bhi chota sa gaant hai. So I was telling him that, tell me, I am a 75-year-old man, if anything wrong, maine cigarette chhod diya tha, ye wo. But he was beating around the bush because maybe it is first interview, and he is going slow or something like that. He is yet to convey me everything, that it is a stage 4 cancer or whatever his prognosis. So this was the discussion. And
so any solutions to that? I mean, that just reflects the difficulty of
no. So we have common people in our group, not exactly oncologists.
Right.
So they were also there. Initially they thought that it is very easy to convey, and we were discussing is it that easy for a doctor to convey on the first go that you have a stage 4 lung cancer, the median survival is around 6 to 12 months. So this is too difficult for our part, and because we are playing dual role, we are also a human being. So those are the difficulties.
Okay. Thank you for sharing. Any other reflections from the other groups?
So what discussion we had was, few of us felt that we should treat the patient, few of us felt that why don't we just offer best supportive care to the patient considering he's 67. So our senior doctors felt that that option should be given to the patient. Second discussion we were having was, if we are not going to treat this patient by chemotherapy or radiation, and then how do we improve his quality of life? So that was second discussion. And then points came up like, let's do only symptomatic treatment, address his cough, breathlessness, headache, and his pain, focus on his nutrition. So those were the discussions, and few of us felt that this is the perfect case where the palliative physician should be incorporated on day 1, and then together we decide how to take it forward.
Any challenges for communication, like what this was described in this group, they were finding it difficult to communicate this news?
No, I think we sit across the table, we deal these cases, so I think.
So biggest challenge here comes is the desperation among the relatives, the close relatives. The expectations of some increase in lifespan, is enormous. And it's easy for academic institute or the bigger, in fact, I don't want to take the best hospital in the country, even in their academic, most of the doctors, they are not very free in talking about in a first visit to tell about the prognosis aspect. Let me be very frank with you, nobody does it. Otherwise, in India, patients are going to change their hospital and the doctor in the whatever coming days. So desperation, how to deal with the desperation and how to deal with the expectation is $1 million question.
Absolutely.
And if you have some suggestions,
sort of point, one single answer to that, and it's a complex issue. I mean, all these discussions that is coming on, it indicates the complexity of the topic. So in the interest of time, I think we'll have to stop.
Just one point.
Yeah, just one, and then we'll move on.
In this case, where the patient is very symptomatic, the first thing that we should be addressing is that we are going to do the best to reduce the symptoms. Forget the disease, forget the cancer, forget the stage 4, forget the treatment, the tests and everything. But first thing, we'll make you comfortable. Rest can be discussed later.
Very
so
nice.
This is the first thing that we can do.
Thank you. So thank you all for active participation. Sorry, in the interest of time, we couldn't have feedback from all the groups. We move on to the next session by Dr. Susie Stanaway.
Can you put the slides up? Okay, hi. Thank you very much for inviting me to come and speak. My name's Susie Stanway. I'm a medical oncologist in the UK. Just for transparency, I'm by no means an expert in burnout, but following on from last year's session on communication skills, we felt that it would be important to have this as a component in this session. So, takeaways. Burnout is significant amongst oncology healthcare professionals and negatively affects ability to deliver healthcare and patient experience. Burnout will contribute to poor communication, and improving how we communicate could contribute to reducing burnout. And there are personal and organisational strategies that can be employed to help reduce burnout. So I think it's important to contextualise this. So of the global deaths, 70% of them are from non-communicable diseases, with cancer and heart disease being number 1 and 2 in prevalence. And we can think about the health system and workforce being one of the most important parts of the health system and what affects that system, but we can also think about these broader existential challenges that we all face, be it recent pandemics, epidemics, be it the effect of climate change and extreme weather events that many of us around the world experience, other existential threats such as artificial intelligence, disinformation, and conflict, with 2 billion people in the world living in countries affected by conflict. And these all affect the way that health systems function. And then on top of these, there are other sort of cross-cutting issues such as demographic shifts, food, energy, water security, the market, the economy, raging inequalities, inequity and urbanisation, which also affect health systems. So with that as a background, the global workforce shortage is 11 million professionals by 2030, as predicted by the World Health Organization. And burnout is a significant contributor to this. So the concept of burnout is a triad of emotional exhaustion, depersonalization, which is subjective, dissociative phenomenon where one detaches from oneself, and a low sense of personal accomplishment. Burnout's often measured using the Maslach burnout inventory, but there are other ways, such as the Copenhagen score and other shorter tools which use proxy measures. And burnout has negative consequences on patients, such as lower satisfaction of consultations, longer post-discharge recovery times, increased medical errors, and decreased professional workload. Prevalence varies between studies. I've quoted here Susanna Banerjee, who's one of my colleagues who's done a huge amount of work on burnout. This is a study that they recently published as part of the ESMO Resilience Task Force, and you can see here across Europe how levels of burnout vary, but they're very significant. And potential risk factors include stressful experiences, quantity and quality of work, work-life balance, young age, whether you're early career or not, social isolation, mental and physical health, with the field of oncology being particularly susceptible because of heavy workload, high emotional and information needs, and exposure to suffering. So I just put down this study that was run by some of our colleagues, which really looked at 65 countries. 36 out of just over 1,000 respondents were from Africa, and it really showed the high workload that clinicians in Africa have, for example, and their low level of job satisfaction. And I think that this is particularly important when looking at lower middle income countries and seeing how adequate workforces are, particularly if you look at tumour types such as breast cancer, that I treat, that's one of the most prevalent cancers diagnosed anywhere around the world, and the biggest increase is going to be seen in the African continent. And we need a contextualized, systematic approach to multidisciplinary workforce optimization. So, relationship between communication and burnout. Communication can be a cause of healthcare professional stress, and yet it can be targeted so that it can be improved. Communication skills training can improve communication and reduce burnout, and that's been shown. And this can take many forms, such as group sessions or reflective fora, such as Schwartz rounds, which we have in the UK, where staff regularly meet and reflect through storytelling on emotional and social aspects of their work. It can be one-on-one or it can be through simulation. So this meta-analysis of over 200 studies looked at interventions to prevent and reduce physician burnout. It was a systematic review and meta-analysis. And they've divided it up into sort of organisational issues and personal issues. So from a personal perspective, things that can help are support services such as counselling, ability to access mentorship, communication skills training, smaller group sessions such as around stress management, stimulating reflection, experience sharing, medical error, and self-care programs such as mindfulness and exercise. I thought this was quite an interesting study. So it looked at the relationship between oncology nurses' emotional intelligence, burnout, and patient-centered communication. It was a cross-sectional study. It was conducted in Saudi Arabia, and I think that it's really important, although I think the fundamentals of being human are the same wherever we are in the world, there are contextual differences, so I think it's important that in our own regions we conduct our own research. And so this just highlighted what emotional intelligence is. So it's an individual's capacity to perceive, understand, regulate, and use emotions effectively in interpersonal interactions. And the aim of the study was to look at the extent to which emotional intelligence and burnout independently predict levels of patient-centered communication. And does EI moderate the relationship between burnout and patient-centered communication? And it was a cross-sectional study of nearly 200 oncology nurses. And the results showed that emotional intelligence was positively associated with patient-centered communication and negatively associated with personal, work-related and client-related burnout. And the conclusion was that emotional intelligence, which can be taught and modified, plays a critical role in reducing the negative effects of burnout on patient-centered communication amongst oncology nurses, and that training should include EI development and wellness initiatives. So, from an organisational perspective, this was published last week. So this was a statement from ASCO, so from the US, from the European Cancer Organisation, from Europe, and also from an Australian group, the CSO. And basically they said that mounting system-level stressors render day-to-day work unsustainable, leaving physicians emotionally depleted and detached with diminished satisfaction and sense of accomplishment. This is burnout, and it's particularly alarming in oncology, a field built on delivering compassionate, comprehensive cancer care. And so what can be done? So this meta-analysis that West did showed that workplace quality improvement activities have been shown evidence-based. For example, shortened rotation length, modifications to clinical work processes, and shortened resident shifts have been shown to improve levels of burnout. This is a Lancet Oncology publication again from this year, which shows principles for advancing healthy workplace cultures. So this is part of that joint statement. And it basically lays out the fact that healthcare systems should commit to healthy workplace cultures through their mission statements, strategic plans, policies, and governance structures. So this is what we should all be doing within the systems that we work within. Healthcare systems should promote teams-based culture, and healthcare systems should involve all members of the team in designing, implementing interventions to improve team functioning and well-being. And healthcare systems should assess team function and individual well-being at baseline and regular intervals to evaluate progress. And so how can these principles be operationalized? So implementation of team-based functioning across organizations using contemporary team frameworks, formation of multidisciplinary wellness or cultural committees with dedicated resources and clear governance authority to drive change initiatives, implementation of quick wins, such as streamlining and harmonizing policies and processes, for example, reducing clinicians' administrative burdens, and conductive comprehensive baseline assessments using validated instruments and establishing regular surveys to track well-being and adjusting interventions based on real-time feedback from this tracking, and embedding well-being metrics into organizational dashboards alongside traditional quality and safety indicators to ensure accountability at all levels of leadership. This was another study that was led by Professor Banerjee and her team at ESMO and looked at times of crisis. And I think that we need to be thinking about developing resilient health systems, whether this is resilience during pandemics, such as when this was conducted and along with another 2 studies which contributed to this, or during extreme climate events, or during centres of places where there's conflict. And so this looked at thematic analysis from qualitative data from 3 global surveys during COVID. And then they highlighted these various domains which showed to be important, such as looking at well-being, looking at safety, and others. And it's well worth a read, really interesting. So what are future directions? So I think there needs to be consistency in the tools that are used. Wide variety of tools should be used and concurrently access for mental illness and medical illness. Further work to define which interventions are most useful in which settings. Research in geographically diverse settings, and research into preventative measures. So takeaways. Burnout is significant amongst oncology healthcare professionals and negatively affects ability to deliver healthcare and patient experience. Burnout will contribute to poor communication. Improving how we communicate could contribute to reducing burnout. And personal and organisational strategies can be employed to help reduce burnout. So I just thought that we could maybe take 5 minutes. I don't know if anybody wants to highlight initiatives within their own organisations or that they've taken personally that have reduced burnout or that could reduce burnout. I don't know if anybody wants to volunteer what's happened in their institutions or amongst their peers or themselves. Professor Dumit.
Hello, good day everyone. Yes, burnout is very well studied in the nurses population, and in my country we did several studies in Lebanon, and it was proven that if we improve the career ladder, if we improve the decision making, if we help nurses to apply leadership in communication, and if we allow them to work to the best of their capabilities and their degrees and their knowledge, this would help in decreasing burnout. We can say money is a dissatisfying factor, but is not a satisfying factor. So money is not everything. We need to provide career ladder and let the nurses sit on the decision-making table, and this would help in decreasing the burnout. Thank you.
Thank you. Would anybody else like to highlight or give examples of Riaz?
Have we got ever data about the impact of electronic systems in managing patients and the frustrations clinicians have in day-to-day practice, and how much that actually contributes to kind of feeling unhappy at work?
Yeah, so I think that's a yes to that, because I came across that in quite a bit of my reading, and the fact that it features in that joint statement I think is also important. So yes. So reducing administrative burden, exactly as you say, the frustration of some of these systems and getting used to them. Yeah. Anybody else like to offer anything else?
So I am a psycho-oncologist, and at my institute, we have listening circles. So we have the doctors come together and they can talk about their frustrations, whether it's with patients, whether it's with family, with the lifestyle they are currently having. We do have an expressive art therapist who takes regular group sessions using different arts, whether it's movement, whether it's drawing, or whether it's music. So we're trying our best to do it, but it's very difficult because the number of patients and the amount of time. But counseling is available for all, and many of the doctors do take advantage of that system.
Yeah, that's fabulous to hear. Thank you. Anybody else before we close? No. Well, that's super. Thank you so much for sharing your experiences. And I think we're going to move on to the next session now. Thank you.
Excellent. So, we've talked about empathic communication, we've talked about avoiding burnout, we've reminded ourselves of what it's like to be in the doctor's chair, in the patient's chair, in the relative's chair. Actually, there's a lot of research and models for improving doctor-patient communication. The reason I got interested in this is that I went to many of these workshops and they were extremely helpful, but nobody told me what to say. And as with many things in medicine, we're expected to be able to work them out from our imagination. Nobody teaches us these things, so I thought this was something that would be worth thinking about. So, 6 things that I wish I'd learnt earlier before I was almost ready to retire. The first one is the principle of ask, tell, ask. The second one is to be prepared, both to know when you need to be prepared and how to prepare for it. The third thing is estimating the median survival time in a group of similar patients. I wish I'd realised how important that was. The fourth thing is using simple multiples of the median to estimate 3 scenarios for survival, a best case, a worst case, and a typical range. The fifth thing is how to explain those 3 scenarios to people. So, if I tried to imagine 100 people in exactly your situation, then I would expect 5 to 10 to die within 1/4 of the median. So let's say the median was 12 months, that'd be within 3 months. 5 to 10 to live longer than 3 years. And the middle 50 to live from between 6 months to 2 years. I'm just using that as an example. We will practice using those words in a few minutes. And lastly, to document in the medical records and letters what we've actually told patients and families about their prognosis. So, what I'm going to be saying to you now is predicated, assumes that the patient or the family has made clear that they want quantitative information about prognosis. It's not that every time you see a patient, the first thing you have to tell them is, I think your life expectancy is blah, blah, blah. It's if the patient says they want information about their prognosis or in some other way prompts you that they want more information. So, the first thing that you might think about asking, I think Yogesh pointed this out a moment ago, is are there things you think we should discuss? That's a question for the doctor to the patient, because many times patients are worrying about their prognosis, but they're too scared to ask their doctor because they don't want to know the answer maybe, or maybe they do want to know the answer. Maybe they're ambivalent. They both want to know and don't want to know. Maybe they don't want to disturb the doctor. They don't want to hear bad news. There are many reasons why it's hard for people to ask this question. If you give the person permission to ask, that's a very helpful start. Another question that's worth thinking about is, what do they already know? We were talking before about how if the patient came in the first consultation with the doctor told them they had cancer, the patient would leave. Most of the time, the patient is coming to see you in a world-recognised cancer centre. Why else do they come and see you? What illness would they be coming to Tata Memorial Hospital for if they didn't have cancer? It is not a secret. Do you want us to talk about how the future might look? That's a possible question. Would you like us to talk numbers and times? Would you like me to go on? These are all things that would be reasonable starting points or intermediate points in the conversation, asking the patient or the family what they want to know, whether they're ready to move on to the next time. And if you ask the patient before you start talking, then it gives them a sense of control over the discussion. It's not them sitting there passively taking the information you're giving them. So what are the doctor's biggest fears? Because a lot of doctors find it very threatening to be asked for information about prognosis. And we've surveyed hundreds of doctors, and typically the main thing they're worried about is getting it wrong. Saying something that's proven wrong. People talk about medico-legal things, being sued because they gave a wrong prognosis. They worry about upsetting the patient or the family, provoking a sense of failure in themselves, and taking away hope. So, how can we not get it wrong? The first thing is never to give a single number estimate. If you say to a person, I think you're going to live this long, you are almost always going to be wrong. If you use ranges, which I call scenarios, they accurately convey uncertainty. They are more accurate. I'll show you some data on that. Actually, they're what surveyed patients want. About 20 years ago, my mentor with psychologists asked a bunch of patients what they wanted to know, and they said, we want to know the worst case without treatment, the best case with treatment, and what's the most likely. That's how we started this idea of worst case, best case, and typical scenarios. And properly formulated, you can never be wrong in an individual. If you use scenarios, whatever happens to the person never makes that prognostication wrong. So, using 3 scenarios for survival when quantitative information is sought, when that's what the patient or the family want, is designed to help estimate and explain survival results of trials. That's one way you can use it. And individualised prognosis to individual people with cancer. And the starting point is the estimated median survival time in a group of similar patients. So what do I mean by all that? You can use simple rules of thumb to formulate these 3 scenarios based on the median survival time. So let's think first about survival curves of randomised trials. That's what many oncologists are familiar with. It's a good starting point. So the scenarios we're going to be talking about are the worst case, which is about the 90th percentile. So that would be about 5 to 10 people died within X. The best case scenario is the best 10%. 5 to 10% of people live longer than. And the typical is the 75th to the 25th percentile of the curve. The middle 50 live this long. So what does that look like? This all seems a bit ridiculous. Here's a survival curve. Here's 2 survival curves. And here are the percentiles. The median is the one that we always talk about. But actually, it's the point of maximum uncertainty. Almost nobody in a group lives for exactly the median survival time. Actually, 50% of people live longer than the median, and 50% live shorter than the median. Actually, telling an individual, it's the part that we're least certain about. The 75th and the 25th percentiles, they're often talked about as the interquartile range, and that's 50 percentage points. That means the middle half of people live between those 2 points. The 90th percentile is the length of time within which 10% of people have died. 90% have lived longer. And the best case scenario, the 10th percentile, 10% of people have lived longer than that. 90% of people have already died at that point. So these are just the numbers off the curves that we look at all the time. So it turns out, and I'll show you in a moment why, based on a few studies we've done, looked at 119 randomised trials, 57,000 patients, and this is published in 3 journal articles, one about breast cancer, one about lung cancer, one about prostate cancer. It turns out that the middle 50 people of 100 live from about half to double the median. That's almost always accurate. The worst case scenario is roughly a quarter of the median. So about 5 to 10 of 100 people will die within 1/4 of the median survival time. And the best case scenario is about 3 times the median. So about 5 to 10 of 100 people will live longer than 3 times the median. So when we looked at these 119 randomised trials, nearly 60,000 patients, those estimates were accurate in about 3/4 for the worst case scenario, about 90% for the best case scenario, and about 90% for the middle 50% of people. So these numbers actually are remarkably good estimators of what's going on. So that's summarising the results of a trial. Instead of saying, in the trial that I'm talking to you about, 50% of people live this long, the median survival, express it as 10% lived longer than this, 10% died within that, the middle 50 lived this long. And then you're not giving any precise numbers, you're giving ranges and probabilities, and no matter how long somebody lives for, that is accommodated in that formulation. So now let's think about individual prognosis for individual patients. So the estimated median survival time in a group of similar patients, that's what we're thinking in our mind. What's the best starting point for that? Think about the trial that is most similar to the patient and the treatment that you're about to start with. So, we've done this in a few studies, in a few patients. It's 7 studies, it's over 1,000 patients now, where we've asked the doctor when they see the patient, actually typically it was before a patient was randomised in a trial of systemic therapy, to estimate what they thought the median survival time would be in a group of similar patients. So they see the patient, they're talking to them about the trial, the patient walks out, the patient's recruited, and the doctor has to write down how long do they think the typical survival time is in a patient like that. Each patient was then followed to see how long they lived for as part of the study they were in. So the median age was about 65, 60% male, 40% had lung cancer. The median expected survival time was about 9 months. The median observed survival time was about 8 months. This is in 1,200 patients in 7 different studies. As hypothesised, calibration was almost exactly perfect. What I mean by that is that 50% of the individuals in these studies lived exactly longer than their clinician's estimate, and 50% lived shorter. So there was no bias. Doctors weren't underestimating or overestimating survival of their patients. They were completely unbiased. Point estimates were very imprecise. Only about 25% of patients lived within 2/3 to 4/3 of the observed survival time. Very imprecise. If you say, even if you get the median survival time right, very few people live for that long. Simple multiples of the median were right almost exactly as they're supposed to be. So, the worst case scenario, about a quarter of the median, about 8% of people, 1,100, lived shorter than that estimate. We say 5 to 10, the answer in 1,100 was 8%. The best case scenario, where we say about 5 to 10 people will live longer than 3 times the median, that was 11%. The typical range, the middle 50, we said that it's supposed to be 50%, it was exactly 50% in the 1,100 patients. So even though we're not very good at getting the survival time in an individual exactly right, we are extremely good at describing a group of similar people. Actually, it's crazy to think that we can do any more than that. This is a very, very high bar. We're already doing very well. And this is not people who are experts in prognostication. This is hundreds of oncologists taking part in randomised trials of treatment around the world. So, 6 principles. The first one is ask before you start telling. Tell something and then ask if it's all right to go on and what they would like to hear next. As a principle, with all information giving. Be prepared. When and how. So at the beginning, I said to you there are 6 or 7 time points when it's worth thinking, should I be prompting the patient or the relatives to ask me about information about prognosis? Just try and remember, we'll come back to it in a second, like what those time points are. Estimate the median survival time in a group of similar patients. In a moment, we're going to do a practice exercise for that. Use simple multiples of the median to estimate 3 scenarios for survival time. Explain the prognosis in terms of those 3 scenarios. So in a second, I will get you to find a person sitting next to you and say to them, if I tried to imagine 100 people in exactly this situation, then I would expect 5 to 10 of them to die within the next X months. I'd expect 5 to 10 to live longer than X years. The ones of you that are quants, that really like numbers, you'll have worked out that a quarter and 3 are 12 times apart. So whatever the worst case scenario was in months, that's the best case scenario in years. And the middle 50 will live roughly half to double the median. And then lastly, when you've gone to all the trouble to say this, write it down in the medical record, put it down in the notes to the patients. And the letters to the doctors, because everybody else will be grateful that that information is available. So I have another 100 slides to go through, but I'm not going to do that. But I do want to acknowledge particularly Belinda Kiley, who is the prognostication guru in Australia. She did a PhD with myself and Martin Tattersall, who is the stem cell of oncology in Australia. and was very interested in evidence-based communication. And then Drs. Sharon Naam, Erin Moth, Shalini Subramaniam, and Anuradha Vasista are people who Belinda and I have supervised through PhDs. They're the basis of a lot of the data that I've been reporting. Our 3 consumer research advocates, all of whom had cancer, some of whom were patients of ours who helped us plan these studies and come up with the information that I'll be sharing with you in a moment. So, what I would like you to do now is to stand up for a moment, if everybody can stand up. Fantastic. And put your arms up in the air and wave them around a little bit. Spin around once or twice. Okay, now you can sit back down again. I'm sorry that I don't have any more chocolate to give you out. It's just to get your circulation and your brains flowing. Can you take out your mobile phone and click on that QR code? And this will take you to our 3 scenarios for survival website, which we will play with in a moment or two, so that you don't have to remember all those numbers and work from them in your head. So what we're about to do now is we're going to look at summarising survival curves with scenarios, formulating and explaining individualised scenarios, and practising talking with each other. Now, having been the time fascist all along here, how much longer have we got for this, 20 minutes? 3 more minutes, fantastic. So, please imagine a 50-year-old smoker who's had 6 months of increasing joint pain, trismus, right neck swelling and 4 kilograms of weight loss. Performance status is ECOG 1. He has loco-regionally advanced squamous cell carcinoma of the buccal mucosa. Palliative triple metronomic chemotherapy is proposed with methotrexate, erlotinib and celecoxib. And the patient asks, how long have I got? Let's forget about the nivolumab. What study are we going to look at to try and work out what would be a reasonable estimate of the median survival time in a group of similar patients? Hand up, please. Which study would be a good study to look at? Yes? I cannot hear you, but I'm going to guess. Yeah, so low-dose immunotherapy in head and neck cancer, a randomised trial, JCO 2022. Let's have a look at the survival curve. There is a survival curve for chemotherapy by itself in blue and chemotherapy with the immunotherapy in red. Let's assume that this person is just having chemotherapy, not going to have the nivolumab as well. Roughly, what is the survival time here? What's the median survival time in this group of similar patients? Shout.
6.4 months.
Yeah, so that's perfect. Is it really helpful if we were going to talk to anybody to say 6.4 months? What would be an easier thing to say?
6 to 7 months.
That would be great too, or even just 6. So, put in your app, it has a little blue box for the median survival time in the middle, put 6 there. And what you will see is it will calculate the worst case, typical and best case scenarios. Is that working for you? Yep. And so what that looks like, I've just put the lines on there, which is half, double, a quarter and 3 times. And now what I want you to do is to turn to the person next to you, pair off with somebody, click on the arrow which is on the bottom of the website, and it will take you to a picture which you can print out at your computer and the words to use. Can you see the words that I did before? If I tried to imagine 100 people in exactly your situation, find a person next to you, just one person, and you practice saying it to them. Once you've said it once or twice, then swap over and get the other person to say it to you, okay? So your time starts now. You should be looking at the person next to you and talking to them. I don't hear any talking at the moment, and this is what being prepared is you do not want to do this for the first time talking to a patient. It's safe in here, you can say whatever you want, nobody's going to be crying or upset. Practice using these words with the person sitting next to you. Try it. So the people who are talking, if they had a chance to do it to the person next to them and for the person next to them to have a go. I can see that not everybody's going to play this game, but I would find somebody you trust and just try it out with them. So the way this website works is that if you go back arrow now, go back to the previous page, you can change those numbers, you can change the median, and it will calculate best, worst and typical scenarios, whatever the median is. What's happening with the slides? Fantastic. So we have a biliary tract example here as well, but we don't need to do that one as well. So what I would love you to try and do is to play around with this website. It's completely free. There's a button up the top where you can copy and paste the information and stick it into something, into a medical record. You can also press the print button and it will come out on the printer next to you. So we've done a trial where we did this with over 200 patients. We gave them a copy of the piece of paper after we spoke to them. We gave a copy to every family member who was in the room. We sent a copy of it to all their treating doctors. And the data was that about 90% of patients, more than 90% of relatives, and 100% of doctors thought that this was useful, removed stress, improved hope, and about 30% of them said it was stressful, but they still thought it was worthwhile. So, we're now going to do recognising and responding to emotions. I'll invite Avanish back up here again. Yep. Thank you very much for your attention, and I'm looking forward to the rest of the workshop.
So now we have come across many cases. There was a quantitative part, technical part, and as I have seen many of my oncologist colleagues, so sometimes they avoid difficult conversation, and sometimes they are motivated to start communication, but in between certain distress in form of difficult emotion comes, and that actually causes sometimes avoidance of the patient. So how we can deal it, how we can practice this is more about introspection, what we can do in our day-to-day practice, rather than giving you a theoretical knowledge about it. So keeping in mind the previous role play and the discussion led by Dr. Martin sir, so how we can recognize and how we can respond to difficult emotion pertaining to the prognostic decision, because it is quite a vast topic to cover. So delivering a prognosis in oncology is not just about facts. What we, the data and the bar diagram shown in the mobile, that is a quantitative assessment of the prognosis. So, but that doesn't end the prognostic communication. It's not just about facts. Sometimes emotion often speaks louder than words. So we have to respect that silence, that emotion. So why this actually matters in your day-to-day practice as an oncology healthcare professional, not just doctor, for nurses also. So prognostic decisions are always emotionally charged. The patient and family will experience grief, anger, denial, collusion, guilt, demoralization and whatnot. And the clinician discomfort can lead to avoidance, misinformation or rushed conversation. अरे यार ये patient भाग तो नहीं जाएगा ना. At the same time, how you can balance between this emotion, difficult emotion, and how you can actually make sure that this patient adhere to the standard treatment. So my objective of this session is to recognize certain emotion and to name that emotion. Whenever you find any kind of distressing expression or behavior from the patient, try to name it. Sometimes you won't be able to name it, but try to name it. Recognize the distress, name the distress and respond to the distress. There are 3 steps for the therapeutic communication and to improve the alliance to the treatment. So I won't be able just to talk about the emotion perspective of patient. We have to talk about the emotion perspective of clinicians also. So patient and family emotions during prognostic discussions are fear, about death, about abandonment, about being suffering the pain, like we see in the role play. Will I be in pain always? Am I going to die very soon? This fear. Then there will be sadness, which anticipated loss. I won't be able to attend my daughter's wedding. Anger. Is this God has been so unfair to me? Why me? I haven't done so. I haven't smoked in my life. Why I have got lung cancer? Denial as a coping mechanism, it like Dr. Yogesh sir said, it is a coping mechanism, but sometimes denial can be very much distressing. And guilt, especially in patients with familial cancer, it has been seen, and especially in patients with lifestyle link related cancers. And I also want to acknowledge clinician emotions about being discomfort during this discussion, being helpless and hopeless sometimes, anxiety about destroying hope. The patient would be attaching you with you since last 6 months, 8 months, and you as a physician will think that probably by disclosing this news, I will be throw the patient into destroying hope. Burnout, like Dr. Susan madam said, emotional fatigue, which will eventually impact your empathy. So it's not necessary that emotional cues will be always verbal. There will be a lot of non-verbal. And sometimes it won't be a verbal, it won't be non-verbal, you have to explore it. So we will talk about all these 3 scenario where verbal cues most of the time come like, this isn't fair. Are you saying I'm going to die? And the repeated questions like, you said sir, the patient will specify certain sentence, it is tumor, it is tumor, it is tumor, it is non-cancer. So repeated questions despite clear answer that this is cancer, this has gone to the brain, he will have this is tumor, this is tumor. So repeated question is coming, that means you need to explore the emotion of the patient. And then you need to name that emotion, and then you can find out, you can adopt your strategy, how you are going to respond to that emotion. Certain non-verbal cues like crying, body languages, tone, avoidance of eye contact, and using of silence. These are also non-verbal cues. What are the frameworks and tools you can explore their emotional status? Their nurse statement, and is for name, understand, respect, support, and explore the emotion. And spike protocol, what Dr. Yogesh sir said, the E part, the emotion and empathy and emotional exploration. These are the tool and framework if you want to unhide or unveil the underlying emotion of the patient. So responding with empathy, once you recognize certain distress in form of emotional concerns, you can actually adopt this practice, the nurse practice. First of all, name. Like example, I can see that this is overwhelming. Second, you can go, I can imagine how hard this must be. So try to avoid the sentence, I can understand, because you cannot understand, you can just imagine. So you can say you can imagine, or you can just say you can't even imagine how hard this must be. Respect, you have handled so much already. We are in this together. So that gives you a personal connection and a confidence that you can take away this communication further. Well, and can you tell me about what is making you worrying? So this nurse statement is very powerful. Whenever I am stuck in any difficult conversation, I have used this model and it most of the time works. So there you will be caught in the scenario where you have to validate, at the same time you have to reassure, but try to avoid false assurance that everything will be fine. Most of the time, to end the conversation, we say everything will be fine. You know, the patient also know nothing is going to be fine. So false assurance should be avoided. Instead, you can see, I wish the news would have been a bit different. Use silence, be present, and sitting is not always passive. It is a very, very powerful support. So be present and use the silence is a very powerful toolkit. That is one input from my side. And maintaining hope without giving false hope is a very difficult start. You will say, Avinash, hope भी maintain करना है, false hope भी नहीं देना है, वो कैसे संभव है? How it is possible? So it is a gradual process. It is not in the won't be happening in single meeting. First, start the discussion, shift the focus of hope, like from the cure to control to comfort to meaningful time, and it can take 3 to 4 meetings. Let's focus on what we can control right now. So you have to bring the patient from area of concern to the area of control. Then you can say what you are hoping for and what you are worried about. And it will actually open the Pandora of suffering, and the patient will give you more domain of their concerns, and gradually you can attend their practical problems. Honesty with compassion is, yes, very challenging, but you can use clear and kind words. The example is the cancer has progressed and it's no longer responding to treatment, rather than saying the treatment has exhausted. Okay, so these are certain points and inputs from my side. And at the same time, not just during handling difficult emotions, Dr. Susan said, the burnout, it is very important to be self-aware, and it's very important to be kind to ourselves at the same time. So try to reflect what has gone wrong in my communication, try to improvise, try to improve and practice it. So that is the key to respond excellently to different kind of distressing emotions. So recognize your triggers and emotional response, use debriefing, take team support, take team of palliative care team, take support of your colleagues, avoid emotional detachment. That is not possible because you are a doctor and you have to be present during this difficult time of the patient. Certain unhelpful statement which I have seen that oncologists use in a day-to-day practice, like nothing can be done, I understand how you are feeling, it could be worse, we all die, everyone has their lot of suffering, don't worry, everything will be all right. These are the sentences we can actually avoid. Just I will give you an exercise how you can use certain alternative statement instead of this. So there is a case which we will be discussing as of now. The patient is asking you, how long do I live? At the same time, the patient is visibly distressed. Demonstrate a poor versus skill empathetic response. Two groups will be demonstrating the poor empathetic response, and two teams will be leading the good skilled empathetic response. Over to the audience. Thank you. How long I will live? How as an oncologist or as an oncology nurse you will respond to the question, or how as a doctor you will respond, because being irrespective of any specialty, how you will respond to this question, मैं कितना दिन जिंदे रहने वाला, how long I will live, how you are going to respond it?
सर से पूछना चाहता हूँ, पहले वो क्या आंसर देते हैं?
As a clinical psychologist, it is very difficult to reply, but still, as a non-medical person, I would say that it is difficult to say. It is difficult to say how long you will live. There are so many factors, medical factors, psychological factors, that will determine. At the same time, your own coping skills or coping mechanisms, whether it is maladaptive coping mechanisms or adaptive coping mechanisms, that will determine.
सर आपने पूरा अवॉइड कर दिया. क्वेश्चन है हाउ लॉन्ग डू आई विल लिव.
I did mention that, like it's
You didn't
difficult to
mention.
mention.
So they are asking, we have to mention. Avinash, your question is, so we have to answer it, na?
How a patient would respond, you mean to say?
No, we have to answer. The physician has to answer.
As a psychologist, I would say that, what I mentioned.
So he completely avoided this. Okay. So he is supposed to answer us or lead us. So he has avoided this question.
Which will arrive after your answer. How long I will live? A preliminary consultation with doctor, and probably eventually we will include your psychologist to handle difficult emotion. But how you are going to answer the patient's question, how long I will live, in a empathic way?
Yes, one is.
My answer would be, from what we have discussed so far, what do you think? And depending on the answer, I would say we will make sure that you will be free of pain, that you will have quality of life, and that we will try to make sure that you will be as much as possible free of symptoms. And I will try to explore also what are your fears, what are you fearing from. So the answer has to respond to my initial assessment of the patients. Some patients would like to know. Yes. Others, they know, but they don't want us to tell them. So we have to really assess their readiness, if they are ready to know and if they want to know. This is extremely important, and accordingly we gear our answer. But I want to thank you for the presentation and say what you have mentioned is easier said than done. And physicians and nurses are not trained to reveal difficult answers. This is why this requires structured training through simulation labs that should be done, and through feedbacks that should be given in order to enhance this aspect of communication, because this is the main cause for burnout. When we know that we are not performing our duty to the fullest, not because we don't want, because we were not trained, because we are afraid ourselves as professionals to talk about it. And we need to be trained, we need to be taught. Medical schools do not teach physicians how to reveal difficult diagnosis. Thank you.
Dr. Avinash, I will be non-empathetic doctor. Like I will say, अब आप इनको hospital मत लाइए, don't bring this patient to hospital, keep him in home till he is there, no drug is going to work, and now इनको दवाओं की नहीं दुआओं की जरूरत है.
So, yeah, we should not be judgmental, but that is actually, we try to avoid the conversation, and these are the quite frequent sentences we use. So, now you have been the poor communicator. So, how you reflect, you can be a good communicator. What you will do instead of saying this?
Like the points you have mentioned, I will discuss, I will avoid that sentences, all the particular sentences like I can understand your, instead of understanding, I can imagine. Then I will, like the Martin sir has put in, that I will, how much patient also want to know, all these things I will see. Then other factors like collusion in family and all other factor I will see.
So thank you ma'am, and thank you sir, you have comprehensively concluded this session. So I have certain inputs that how long I will be for oncologists. Certainly try to acknowledge the emotional weightage in that question, and you can definitely say it is a very difficult question to answer. Naturally there are so many variables, and I will try to give you certain scientific estimation, because saying it exactly is not possible as of current scientific estimation, and these are just possibilities, and many of patients with treatment do good also. So don't be so much hopeless in that situation, and these all estimation are based on statistics, but we are there to make sure that you get best possible treatment. And would you like to talk about your treatment preferences and what can I do to feel you better? So these are the certain pointers, these are the sentences what I say whenever patient asks me this.
So Martin sir and Avinash, they are saying that till now we have been giving them estimates, and what Martin sir said, that probably we are wrong in most of the time. That's why he has given a 12x range, that 1.5 month to 18 month is the range. So whenever we try to talk in terms of months, we will be most of the time wrong. That's why even this clinical psychologist, he completely avoided the time. And your final summary also said that there are various factors which will determine. These are the ranges of 12 times. So we have, and madam said that we have never been trained actually. At this age, after so many years, we are being taught at the end of the session that this is the most important thing that will avoid the burnout. I have myself, I have felt in last 15 years, I have this burnout thing. That is most important. The academic session was not important, rather the burnout on our part was very important. So whenever we try to give the estimate, we will, in most probability, we will be wrong.
No.
So could I take the microphone back again, please? Thank you very much. It's been a fantastic discussion. I think we're all getting hungry and grumpy. So if we can go back to the slides, we are running late now. So I was wrong about how long we had. I wish we had longer, but we don't. I can only imagine how difficult this is for us all, because none of us have eaten. We're all starving. I think we've had a fantastic session from Yogesh about communicating empathically, from Susanna about avoiding burnout, from Avinesh and the team, Hashita and Savitha, and for the role play, which was superb, and something about the scenarios. So what I want us to do is to think about repeating, thinking about what we're doing and practicing. So of course, 2 hours before lunch on a Sunday is not going to change us into master practitioners of communication. However, understanding that we can do it better, deciding that we are going to train ourselves. Unfortunately, no university, no college is going to put the effort into it. It's our responsibility to do better. It's a fundamental skill for oncologists. We can do it better, and if we do it better, we will be more satisfied, we will do a better job, and we will be less burnt out. So I think I would encourage you, what I do when I'm driving to the clinic in the morning is I think, okay, in today's clinic, what am I going to try and do better? One thing, I'll try and finish quicker. I'll try and support the registrar better. Maybe I'll ask to try and encourage more conversation. Just one thing every week. And then after the clinic is finished, how did that go? Oh, that went well. Actually, I could have done that better. This should be part of our daily practice. That's how we become excellent clinicians. And the other thing that helps us become excellent clinicians is working with great people. So I'd like you to join me thanking the faculty who've done, I think this has been an incredibly enjoyable, successful, challenging workshop. And I look forward to meeting with you and hearing from you over the next year or two as you improve your communication skills with your patients. So thank you for your attention and your exercise. And I think now we have lunch.
No, sorry sir, sorry to interrupt.
No, you don't have
lunch? No, no, not yet.
Okay.
On behalf of the organizing team, we extend our heartfelt gratitude to our faculty and session chairs and all the participants for engaging wholeheartedly in this workshop. I would like to request the chairpersons to give a comment or two. Comment on the workshop.
Well, that was amazing. I had the easy job, but it was really interesting to see how you guys all interacted. I could tell that the audience were really engaged and absorbing everything that was being said. I really hope that you've learned something that you'll practice in your clinic. When I was a junior, we would try different ways of, we're all different. We have different personalities, different ways of interacting. There's no one way to do it, but you've got to find a way that's fluent for you, that you're comfortable with, that your patients are comfortable with. And have someone in a clinic room, have a nurse in a clinic room when you give bad news, and ask them at the end, did that go well? What do you think? What could I have done better? And I've always found that helpful. So with that, we'll close.
Good afternoon all. The next program in our agenda is the announcement of winners of poster presentation. On yesterday afternoon, the esteemed jury of Dr. Shailesh V. Shrikhande, Dr. Shona Nag, Dr. Aruni Ghosh, Dr. Sheikh Rawat, Dr. Nilesh Jain and Dr. Deba Dulal Biswal have judged 25 submissions categorized under case reports and peer reviews. Amongst the 18 peer review submissions and 17 case reports, we have top 6 posters which will be published through the eCancer with the kind assistance of Dr. Aruni Ghosh. May I call upon Dr. Alok Kumar Swain and CA Samiksha Srivastav to grace the occasion and give prizes to the winners. Poster number 18 by Dr. Jaspal Singh, third year student of MCH program of Department of Surgical Oncology at TMH Mumbai, gets the third prize, the prize money of cash 10,000 rupees. Dr. Jaspal Singh's title of poster is Anaplastic Carcinoma of Thyroid, a 4-year experience in a tertiary care cancer center. Congratulations, Dr. Jaspal. The second winner is Dr. Palak Agrawal. She gets a prize money of rupees 15,000 for the poster title Impact of Time Interval Between Surgery and Commencement of Adjuvant Therapy in OSCC, a 6 months analysis of our institute. Dr. Palak, congratulations. And the winner is Dr. R. Senthil Kumar with a prize money of 25,000 rupees for the poster title Uncovering the Spatial Hotspots and Epidemiological Trends of Cancer, a retrospective study from the Central India between 2019 to 2025. Amongst these, we also have poster number 17 submitted by Dr. Saurabh Tiwari on Bridging Evidence and Practice, a 7-year institutional audit of endometrial cancer amongst the top 6 posters. And poster number 16 by Dr. Prabhakar Gupta, who is a student at AIIMS Raipur, and the title of his poster is Predictive Value of P16 in Patients of Esophageal Squamous Cell Carcinoma treated with Neoadjuvant Therapy. And poster number 10 by Mr. Deepak Rangdale. The topic of his poster is Retrospective Clinical Audit of Factors Leading to Incomplete Radiation Treatment, Analysis, Recommendations and Re-audit. All these 6 posters will get an opportunity to be published through the eCancer portal with the kind assistance of Dr. Aruni Ghosh. I congratulate again all the winners of poster competition. Now, may I please call upon Dr. Bhavna Sirohi for valedictory session and thank you note, and we will like to complete the session with ma'am's note. Dr. Bhavna Sirohi, please.
Thank you, Shubhangi. I'll be very brief. I'm between you and the lunch. I'd just like to thank our patron, Mrs. Agarwal, the whole BMC staff for putting the conclave together in the last 2 months and working literally day and night in making this happen. So thank you, team. I'm so proud of you. Especially the 3 organizing secretaries, Dr. Devakar Pandey, Dr. Yashwant Kashyap, and Dr. Gaurav Gupta, and also our international and national faculty who have, and regional faculty who have come here, given their time, educated, and been part of the whole conference wholeheartedly. I'm so grateful. Especially Martin for the research workshop and the communication skills workshop. This was unique. For the first time, you had weekly meetings, to make this happen. So, I am so grateful, I can't tell you. The research workshop, the surgical workshop, all the workshops were oversubscribed, and this is a very high bar you have made us set, and we feel that we have to kind of deliver on this every year. The conference wouldn't have happened without the support of our industry partners, to whom we are extremely grateful, and also to our academic partners, American Society of Clinical Oncology, eCancer, Common Sense Oncology, Chhattisgarh Oncology Association, Chhattisgarh Hematology Association, Tata Memorial Hospital, National Cancer Grid, and NAG Foundation, and last, Anil Agarwal Foundation. And of course, I would like to thank the delegates who have joined in person and online. Very grateful. Thank you so much. And we'll meet next year in September. Thank you. So let's join for lunch outside, please. Let's have lunch. Thank you.
Before breaking for lunch, can we please have a quick photo? Can everyone just come to the dais and we move from there?
Everyone please join. This is not Team Balco photo, it is Team Conclave photo. Team Balco photo will be after lunch, I think. Everyone please join on the dais. Everyone please. Dr. Christopher, sir, please join on dais.
Chris, come.
I feel like royalty now. This is like an episode of The Apprentice, and Barbara's about to say you're fine.
Guys, sit down. Let's fill the chairs.
Cheese. Cheese. Smile, please.
I would like to. It's not working. Hello. I would like to invite all the Balco employees to join.